Good afternoon and welcome to the Health and Government Operations Committee hearings. We will be hearing 12 bills today. We have 53 witnesses to testify. First up, we have Delegate Pena-Melnick with House Bill 1034. Before we get to that, I'll just remind people who are watching of our committee rules. We have 5 minutes from the bill presenter, followed by 2 minutes for bill proponents and 2 minutes for bill opponents, 5 of each. And if we have folks testifying favorable with amendments, they will also get 2 minutes each, up to 5 witnesses. So with that, I will call Delegate Pena-Melnick with House Bill 1034, State Board of Examiners of Nursing Home Administrators, Renaming and Licensure of Assisted Living Managers. Delegate Pena-Melnick.
Thank you, Chair Kelly, and good afternoon, Chairman Pendergrass and fellow committee members. I'm pleased to present House Bill 1034. I'm going to be sharing my time with Dana Kaufman. This legislation will provide oversight to assisted living managers in an effort to provide a standard of quality of care to all Marylanders in these facilities. Maryland is home to more than 600 assisted living facilities throughout the state. Adults often turn to assisted living facilities when they're incapable of living safely alone and require support for daily tasks. This bill will play a central role in setting and enforcing standards of quality for formal long-term care in assisted living facilities. Assisted living management will benefit from a board that will provide regulated, standardized oversight in a formal way to manage complaint. The oversight of a board will ensure that these managers are focusing on what matters most, the people in their care. We need a way to know that assisted living facility residents in our state, parents, grandparents, friends, family members, are receiving the quality of care they deserve, regardless of the facility in which they reside. During the past 2 months, we have worked diligently with advocates and representatives of the industry. I'm happy to accept the amendments proposed by Lifespan Network and the Health Facility Association of Maryland. I think that Maryland will be in a great place and will join 15 other states, including Delaware, New Jersey, and Pennsylvania, where board oversight is required. Thank you so much, and I hope you give this a favorable report. Dana Kaufman now will go ahead and discuss the amendments. Thank you so much.
Thank you very much, Delegate Pena-Melnick, and thank you for working with us on this legislation. For the record, my name is Dana Kaufman. I'm here on behalf of Lifespan Network. And the purpose of these amendments are, as Delegate Pena-Melnick said, is to provide accountability similar to other professions, but we also want to maintain operational consistency within the industry. And the industry, as you know, is regulated by the Office of Healthcare Quality. So just for sake of time, I'm going to talk through some of these amendments, and we are in the process of getting them drafted. But the first issue we wanted to talk about and have an amendment on is board structure. The proposal has the Board of Examiners for Nursing Home Administrators being renamed the Board of Long-Term Care Administrators, which is similar to other states. The composition in the bill has 6 nursing home administrators, but then only 3 assisted living managers. Given the number of assisted living managers and nursing home administrators, the amendment would equalize that representation. So we would both have equal representation on that oversight board. The next amendment deals with the training requirements. A couple years ago, back in 2006, your committee did pass legislation 19-1807, which put forward a 80-hour manager course, which also includes 20 hours of continuing education requirements. The legislation talks about training as approved by the board. The amendment would cross-reference the 19-1807 section so that we would be maintaining that 80-hour course, which right now is offered through all community colleges and 17 private vendors. And just to let you know, that course is very much outlined in regulations down to the subject and the hours that each subject has to be taught. The second is, again, the education requirement. The assisted living program does have COMAR regulations on the assisted living requirements, education for the manager. And we would once again not want to recreate the wheel, but cross-reference that. And just to let you know, like, for example, if you're working in a level 3, you do have a higher education requirements than those who might be in a level 1 or 2. Similarly, with 1807, when you originally passed that, there was grandfather provisions. We want to make sure that those extend over to this new section of law. And lastly, we would like to have a report come back on the implementation timeline to make sure that before applications are accepted, that the board has the resources and the tools it needs to successfully implement this. So we're not in a lurch at the effective date. And that's going to be both staff and technology. So with that, I made my 3 minutes. Thank you very much for your consideration.
Absolutely. Thank you so much for being considerate of our clock. The next witness is Sierra Lee.
Good afternoon. My name is Sierra Lee, and I'm the Executive Director of the Maryland Board of Examiners of Nursing Home Administrators. I would first like to thank Chair Delegate Shane E. Pendergrass and Vice Chair Delegate Jocelyn A. Pena-Melnick of the committee for the opportunity to provide testimony for the House Bill 1034. Please know that 2 days ago, it was brought to our staff's attention that amendments to the bill are currently being drafted. The board will review the official language of the referenced amendments once they have been drafted and finalized. I come to you today as the administrative representative of the board office and to emphasize the board's support of House Bill 1034 for the following reasons. First, the bill promotes public safety and protection, which is the primary objective of the board's mission. And secondly, it encourages and promotes professionalism, accountability, and responsibility for assisted living managers in Maryland. The Office of Healthcare Quality, OHCQ, is the state body that regulates assisted living programs in Maryland. And according to their annual report and staffing analysis for fiscal year 2021, the 10th most frequently cited deficiency was associated with AL manager practices. And from my understanding, sanctions are not imposed on AL managers, and there is no process for posting public orders against AL managers for public knowledge. With the current regulatory oversight, AL managers are allowed to circumvent discipline and liability. So Maryland, compared to other states, has a high acute long-term care facility population and requires more health expertise, especially during COVID-19 and infection control deficiencies rising. House Bill 1034 is extremely important. It will strengthen the collaboration between OHCQ and the board. And most importantly, the protection of safety of residents. We ask that you take this in consideration and vote favorably for this bill. Thank you.
Thank you very much. Next up, we have Stevan Ellis.
Hello, thank you, Chairman Pendergrass, Vice Chair Pena-Melnick, and members of the committee for hearing my testimony today. My name is Stevan Ellis. I'm the State Long-Term Care Ombudsman. I advocate for nursing home residents and assisted living residents. At this time, Maryland has over 1,600 assisted living facilities with over 25,000 assisted living residents. In assisted living facilities, residents receive assistance for activities of daily living by a caregiver and a medication technician. The assisted living manager is responsible for overseeing and coordinating the care of the residents with limited support from the delegating nurse, who is not required to be on site and often only visits every 45 days or as needed by state law and regulation. Even though many of the assisted living residents have the same needs and same acuity levels as nursing home residents, there's no interdisciplinary team, as there is in nursing homes, to help develop the treatment plan and provide the care. This falls on the assisted living manager. The assisted living manager has the authority and responsibility to ensure that residents receive the best and most appropriate care possible. Currently, there's no licensure standards for assisted living managers, and this bill would put this in effect for the first time. The other benefits of the bill would ensure that licensees complete all necessary requirements, that public information would be available to residents and families, which would really assist with informed consumer choice and transparency. Unfortunately, the Ombudsman program has seen very serious issues in assisted livings that could have been prevented by the assisted living manager. So I wanted to go through a few of those. Not having appropriately trained staff, not having heat, not having food, exploitation, being denied access to records, not allowing visitors, physical and psychological abuse, abandonment, and violation of state and fire county codes. Running an assisted living license, unlicensed assisted living. I really do encourage you to support this bill that would give accountability for residents in facilities and assisted living managers. Thank you.
Thank you very much. Next, we'll hear from Felicia Anthony.
Good afternoon. I would first like to thank Delegate Pendergrass and Delegate Pena-Melnick for this opportunity to provide testimony for House Bill 1034. I am Felicia Anthony, the Board of Examiners of Nursing Home Administrators Chair, a certified assisted living manager, and a nursing home administrator. Please allow me to review what I believe to be some of the important facts that support the requirement of assisted living managers being licensed. It is a fact that there are no professional penalties to assisted living managers that do not protect our seniors under their supervision. It is a fact that the caregivers working under the assisted living managers are not required to be certified or licensed or experienced hands-on caregivers. A person can actually be a security guard at 7-Eleven and train on the job on our loved ones instead of being trained and certified prior to starting their job. It is a fact that there is no mechanism to monitor potential criminal actions after hire, for example, a rat-back check. It is a fact that the assisted living manager is the main on-site professional personnel that oversee care. The delegating nurse is only required to be on site at least 45 days, at least every 45 days, as was mentioned. It is further a fact that the assisted living manager certification does not expire. It is basically an on your honor system for us to get our continuing education credits. What we are deciding today is if we will position our seniors in an environment that improves their protection or not. Essentially, assisted living managers, unlike other healthcare professionals, do not truly have skin in the game. It is our ethical responsibility to support this bill, to require the licensing of assisted living managers, managers that oversee and often set the culture and expectations of non-licensed caregivers. On behalf of our current Maryland seniors and those of tomorrow, I request of you to please pass this bill. Thank you.
Thank you very much for your testimony. Claudia Baylog.
Thank you, Delegate Pendergrass and Delegate Pena-Melnick and members of the committee. My name is Claudia Baylog. I'm the lead researcher with 1199 SEIU, the largest healthcare workers union in the nation, representing thousands of workers in long-term care facilities, including assisted living in Maryland. Our union supports HB 1034, and we hope to see a favorable report from this committee. Our healthcare industry is amid a staffing crisis, and the workers who provide care in assisted living facilities are no exception. We don't envision any improvements to the staffing outlook in assisted living without Maryland first taking steps to ensure more accountability in this industry. That's one reason why we support the efforts of the Vice Chair to address quality concerns this way. We've heard about the growth and churn of these facilities and our acuity levels being the highest in the country. I want to take the rest of my time to talk about why those acuity numbers need to be placed in the context of our state's total cost of care model. So Maryland's total cost of care model reflects our commitment to reducing Medicare hospital spending and improving hospital-based care, but it also reflects the value of what we place on what happens to a patient after they're discharged from the hospital. Patients must be released into care settings where they're safe, where their chronic conditions are well managed, and most importantly, where they're not readmitted to the hospital. That means that the continued success of our long-term care settings means that they have to operate under the highest standards of quality. That's the context we keep in mind when we say the state must also recognize the importance of assisted living facilities in our entire healthcare system and the costs they incur. They're a crucial component of our healthcare delivery. So I just want to thank you for allowing me my time this afternoon and hope that there's a favorable report coming out on this bill.
Thank you so much. That is the last witness on the proponents panel. Do we have questions for this panel? Delegate Cullison.
Thank you very much, Madam Chair. And I want to thank the Vice Chair for this bill and her panel for being so compelling and articulate. I just have one question. I just did a quick read of the bill and I didn't hear this. in the conversation, but I'm wondering, are we clear in that we are requiring current managers to meet these requirements? And how long do they have to meet these requirements that are specified in the bill? And I'm not sure who's the best person. I guess that's Dana, who's the best person to answer.
Well, so right now, the assisted living programs can only employ a manager who has met the education and the training programs. So we do not anticipate that changing. The grandfathering will still require them to meet those requirements. I will say, and I will add that for those training programs, back when the legislation was passed in 2006, the General Assembly did not apply those training requirements to the 4 beds and under. This bill will.
Okay, great. Thank you very much, Madam Chair.
Delegate Saab.
Thank you, Madam Chairman, and thank you, Delegate, for bringing this bill. Delegate Collison asked my first question. So my second question is, I was looking over at the fiscal note, and maybe you can shed some light on the difference in the fiscal note on salaries and fringe benefits from 24 to 25, almost 3 times, but yet still the same number of positions. Can you explain the difference between why did it go up from 99,576 for 2 positions to 264,798 the following year?
Would that be the board?
Yeah, I think that's appropriate for Sierra Lee to answer. Is she?
Yes, I'm here. Thank you. So with that being said, we are thinking of the revenue that is coming in. And so with the 1,700 new licensees that would be coming in, the amount of the revenue would actually go up.
Right, but the salaries and fringe benefits go up from 99,576 to 264,798. We're not talking about we're just talking about the salaries, okay, not the board. The fringe benefits for the 2 positions that have been created.
Yes. Well, actually one salary actually was just recently reclassed to an administrator 1, and then we have a reclass for a health occupations investigator that is becoming permanent, and then we will also in the plans be reclassing another health occupation investigator from a level 3 to a supervisor. So that is part of probably the increase as far as salaries go.
So it will be 2 different people with 2 different new positions with different salaries?
Not 2 different salaries. Well, they're going to be, one is being reclassed, so that's a higher salary. And then as far as the investigator, that's not being reclassed, it's just being reclassed into a permanent position. That salary will stay the same.
And with the increase, just to follow up, with the increase of licenses, do we need to increase the amount of people to process the licenses? Because you're going to have a lot more people applying to get the license.
Let me just remind Delegate Saab that we're going to have the opportunity to discuss this in subcommittee as well. These are very important questions, so I appreciate that. So Sarah, if you want to answer that now, that's great, but we can also come back to this.
Thank you.
Yes. Yeah, I would like to come back to this. Thank you.
Sure. Delegate Lewis-Young. Delegate Lewis-Young, I think you're on mute.
May. Okay, thanks. Thanks, Madam Chair. While I'm totally supportive of the intent of this bill, and I think we've recognized for a while the necessity, I'm also cognizant of the shortage of healthcare workers, particularly in the long-term care industry. Has there been any conversation about how this might affect that challenge?
I'll let the board handle it.
I'll go ahead and answer that. Thank you. I believe that this actually would help the shortage and staffing challenges in healthcare. We would be, again, licensing more individuals. Therefore, it would be more people to be able to have oversight of those facilities.
Thank you.
Thank you.
All right, I see no more hands up, just double checking to make sure. Delegate Hill, Delegate Hill.
Thank you, Madam Chair. I'm just trying to read this through, and I have at least this one concern. I'm looking here in the section that talks about if an assisted living manager is incapacitated, that the program shall immediately designate a licensed assisted living manager. And as I recall, in other situations, nursing home managers, and I think even with coroners, or rather funeral owner people, we have a little give in there because sometimes it's difficult to find someone with the same qualifications immediately. And that can cause a problem where suddenly you've got a place with 2 residents or 102 residents and you don't have a manager. So I'm wondering, and maybe Dana can address this, why we're talking about immediately and we're not looking at language that we've done for other folks, or if maybe there's something else. I'm just seeing the bill, maybe there's something I'm missing about how that would could be taken care of immediately.
Sure. I'd be happy to answer that, Delegate Hill. So actually the legislature already took care of that problem. And there's a statute already in place that I think would be valuable to bring over. But assisted living managers, so typically if the nursing home administrator is incapacitated, they will appoint their director of nursing. Assisted livings don't have that, but we do have an alternate manager that can be appointed. But then there's also a process for giving a grace period for that individual to also meet the requirements. So, and I think that is important for consistency in the industry.
Thank you.
Excellent. Seeing no further questions from the committee, there's no one signed up in opposition on this bill, so that concludes the hearing on House Bill 1034. The next bill we will be hearing is House Bill 747, Delegate Kerr, Maryland Healthcare Commission Nursing Home Audit. Delegate Kerr.
Thank you, Madam Chair. HGO colleagues, I'm Delegate Ken Kerr in support of House Bill 747, Maryland Healthcare Commission Nursing Homes and Assisted Living Facilities Audit. What a difference a day makes. I'll get to that in a minute. But as a member of the State Oversight Committee for Quality Care in Nursing Homes and Assisted Living Facilities, I work with advocates, industry representatives, regulators, and Delegate Belcastro to identify and address concerns at our nursing homes. The role that nursing homes play in our state's total cost of care model can't be ignored. A strong healthcare system in Maryland must include fully staffed, financially viable nursing homes. I'm proud of the work we did last year with House Bill 674, a bill that will require increased quality surveys of nursing homes that have been sold to out-of-state operators. That bill gave us an important tool. As the Maryland of Healthcare, the Office of Healthcare Quality has reported that we should expect as many as 6 of our state's nursing homes to transfer to an out-of-state operator this year. So there's still a whole lot more work to be done, and we're missing important data about the finances and sustainability of this vital industry. Nursing homes already file cost reports to the Center for Medicare Services and to the state. And our Healthcare Commission already tracks utilization and volumes and financial information. These are reviewed when nursing homes change owners. Still, there are questions about trends in the industry, such as, are the nonprofit facilities faring worse than the for-profits? Are there other trends we can identify across ownership chains? Are some regions more prone to problems with continuity of care because their facilities are financially struggling? So with 30,000 beds across the state, we must have a better understanding of the finances of this industry. Improved transparency is a starting point for us to be able to enact policies that improve quality and financial sustainability. This type of transparency already exists in Maryland for hospitals. The Health Services Cost Review Commission regularly audits the finances of hospitals and provides the public with detailed updates on their financial performance, along with other important trends. Because of this, we can respond quickly when issues arise in hospitals. Anyone can find an audited financial statement for every hospital in the state on the HSCRC website. However, currently you can't find a cost report for a nursing home anywhere on that website. We have a responsibility to ensure that patients discharged from hospitals who require skilled nursing and rehab are placed into nursing homes that are able to pay safe staffing labels, PPE, training, and infection control. This bill is an attempt to improve transparency in this industry. It's not intended to create duplicative reporting on the part of the nursing homes. It's not asking nursing homes to report any additional information that's not already on their cost reports. It is asking for the state to provide stakeholders with information about the industry that is more accessible and understandable than what we currently have. After listening to the concerns of the Maryland Healthcare Commission, the advocates and I are proposing to amend the bill to be more specific in just what we're asking the MHCC to do. The amended bill would require MHCC to publish a comprehensive annual report for the public that would be published on the MHCC website. The report will include each change in ownership at a nursing home, trends in utilization by facility, ownership group, and by region, a summary report of the financial data that's included in the public use data sets. We also call on the MHCC website to include links to cost reports filed by nursing homes. Increased transparency is an important first step in our ability to make sound decisions in our long-term care system. I want to thank all the stakeholders for working together on this bill. The proposed amendment satisfies almost all concerns. The amendment was just distributed last night, and Lifespan has indicated that they need a little bit more time to look at these changes, as Dana Kaufman will explain, no doubt. So I want to thank you for your consideration of the bill and the clarifying amendment.
Thank you, Delegate Kerr. Let's hear from Claudia Baylog.
Thank you, Chair, Vice Chair, and members of the committee. Again, for the record, my name is Claudia Baylog with 1199 SEIU. Our union supports HB 747 with the amendments submitted, and we urge this committee to issue a favorable report. We know that transfers of ownership in this industry will continue. In our experience, the first thing new owners like private equity investors will do when they buy a distressed nursing home is slash wages and benefits. We saw this last year outlined in an expose by the Washington Post. We believe this legislation gives us a tool to help us address these concerns. Too many stakeholders right now are flying blind when it comes to understanding the finances of our nursing homes, and this isn't because of a lack of data. We do believe the state can provide better synthesized information of our existing data for stakeholders who are looking to develop solutions. So for example, we know we need to broadly increase staffing levels at our nursing homes, but that comes with a price tag. It requires an understanding of the stability of the industry. The financial data that's currently released to the public is opaque. It's embedded in data sets that aren't really usable for most stakeholders. We need to know how many nursing homes in Maryland are vulnerable to acquisition by operators who would put profits over quality. We need to understand the trends based on ownership. Most importantly, we need to ascertain the viability of our good established operators. We want to ensure that they can stay in business. What this legislation now seeks isn't an audit, it's a summary report of the yearly trends in financial performance and utilization by ownership. That's a great step for transparency. I want to note other states are doing this. Massachusetts published a report in 2019 that looks a lot like what this bill is seeking. They also have a dashboard that includes financial data for every nursing home in the state. So with all of this in mind, we appreciate the efforts of Delegate Kerr, and we hope this committee will give the amended HB 747 a favorable report. Thank you for allowing my time this afternoon.
Thank you so much. Do we have questions from the committee? I don't see any hands up. Giving it just one more second. No hands on this. Thanks so much. Let's hear from Dana Kaufman, who has signed up unfavorable.
Thank you very much, Chair Kelly, members of the committee. Once again, my name is Dana Kaufman on behalf of Lifespan Network. And as Delegate Kerr said, we did receive the amendments last night, so we really haven't had a chance to digest them. So this is not going to be my final answer, but when I look at the amendments, I still do have concerns, and I just want to point a few of these issues out. And I think why we appreciate that this is not putting an additional burden on nursing homes to do additional reportings or audits, we are concerned about really what are we trying to get to, and is the Maryland Healthcare Commission, with their limited resources, the best place for this? And I just want to point out a few things because I still think that there's a lot of duplication. So the first issue here says that the report shall have a change in ownership of the licensed nursing homes. We fully support more transparency with the change of ownership. But if you go to the Office of Healthcare Quality's website, they have a web page dedicated to change of ownership. And if you scroll down to the bottom, you can see every nursing home that has had a change of ownership, the old and then the new name. So we think that that is duplicative. It talks about trends in utilization, but we still think that that is unclear. And if you want to have transparency on choosing a nursing home, I will tell you to go to the Maryland Healthcare Commission's website, because it is a searchable database right now that talks about family surveys, quality ratings, staffing, daily rates, whether that they're for-profit, not-for-profit. It is actually extremely helpful for the consumer. And then the last page is looking at this financial data and cost reports for health planning. That information is submitted to Medicaid, and it's done by Meyerson, an accounting firm. So if we're going to be asking for this, it seems like it would be better to go to the source and not have the Maryland Healthcare Commission have another responsibility, again, given their limited resources. So with that, my time is up. So thank you very much.
Thank you very much. Do we have questions for Dana? I don't see any hands at the moment. I'll give you all just one more second. Perfect. So that concludes the hearing on House Bill 747. Thank you so much. Next bill up is a Delegate Kelly bill. It is House Bill 1051, Elderly Individuals, Howard County and Montgomery County Adult Day Health Care Services Pilot Program and Task Force. So this bill, I will go ahead and introduce it and then send it off to my panel. It is related to adult daycare services. Obviously, these centers are growing in importance, particularly as the population is aging. And for many years, Maryland has offered adult daycare services to eligible Medicaid enrollees. And these services are also available on a self-pay basis for non-Medicaid beneficiaries. One reason adult daycare services are eligible for Medicaid reimbursement is because otherwise these people may be in a nursing home, which is, as we all know, much more expensive level of care. During the pandemic, adult daycare services were forced to close, and providers had to scramble to provide certain services to these enrollees, often at home. As the COVID risk remains high for this vulnerable population, many former and prospective adult daycare center participants are now unable or unwilling to resume their attendance. Nevertheless, this population needs these essential services that adult daycares offer. So over the interim, Senator Feldman and I learned of a very interesting pilot program that was being conducted in Massachusetts with an adult daycare center and a health carrier that tests the efficacy of providing these services remotely using an integrator to access services. So the idea of House Bill 1051 is to try a similar pilot in Maryland. I'm going to let the witnesses give the details on the specifics of that, but just a couple of things to note. It does have a task force which will report back to us, and the bill sunsets in 2023. We think that the use of technology and an integrator will have significant benefits for the population. And another potential benefit could be a decrease in utilization of emergency rooms, which is something we're always looking for, because sometimes there's not an actual need for emergency room services for this population. Adult daycare enrollees living at home do experience significant social isolation. And it's our hope and belief that regular contact with an integrator would alleviate this problem and divert such concerns to a more appropriate and less costly service provider. The fiscal note indicates that the program may also result in savings over the long term. You'll also note in the fiscal note and in the letter from MDH that there's a suggestion that this pilot would require a federal waiver. We don't believe that's correct. The program is voluntary. There's no mention of reimbursement of the integrator, and it was designed specifically that way with that in mind. There's also a friendly amendment from the Alzheimer's Association that would add a consumer participant to the task force, and that is perfectly acceptable to us. With that, I'm going to turn it over to my panel to further discuss this, and the first person to speak is Bryson Popham.
Thank you, Chair Kelly, and good afternoon to you, to Chair Pendergrass, Vice Chair Pena-Melnick, and your fellow committee members. Thank you for that fine introduction. My name is Bryson Popham. I'm here today representing Sevita Health, which is a licensed adult daycare provider in Maryland. And as Delegate Kelly has presented the bill, she's absolutely right. Let me offer you a slightly different perspective. Let's do then and now, then being pre-pandemic. Pre-pandemic, the vulnerable population, which is about 6,000 total in Maryland, that use these daycare centers, went to the centers during the day. They couldn't do that during the pandemic, but they still needed their services. Hence the need for some of this subject matter for House Bill 1051. I direct the committee's attention to the definition of integrator on the bottom of page 3 of the bill, lines 25 through 28. There are two key terms in that definition that I'd ask you to remember. One is voluntary, as Delegate Kelly pointed out. This is voluntary. Anyone who participates is doing so essentially at their own expense. And the verb that's appropriate there is coordinate. It is not a medical service. That's important and supports our view, as Delegate Kelly stated, that there will not be a Medicaid waiver needed to allow this pilot to go forward. It is set up for Howard County and Montgomery counties because that we think will give a critical mass to the study. We have contacted both of those counties. You have a letter of support from Montgomery County in the file. I have reached out to Howard County and as well, and we expect a substantial amount of support from them. I'm going to turn this over, with your permission, Delegate Kelly, to Mr. Jeff Wright, who is the state director in Maryland and other states for Sevita Health. He can tell you more about the program.
Next to speak is Jeff Wright. Thank you.
Thank you, Mr. Popham. Thank you, Chair Pendergrass and Chair Kelly and committee members. My name is Jeff Wright. I'm the state director for Sevita Health. I'm here today for support for House Bill 1051. Sevita Healthcare is the largest provider, or one of the largest providers, of medical adult daycare services in the nation. We have 42 centers across 5 states. Here in Maryland, we have 7 centers. 4 are in Montgomery County, 2 are in Howard County, and 1 is in Baltimore County. We serve about 800 individuals on a daily basis here in Maryland. Maryland has approximately 110 licensed medical adult daycare centers, serving roughly 6,000 individuals. Back in March 2020, when COVID hit, all the centers were forced to close. The providers needed to pivot at that time. We've reopened most of the providers in the state, but we're only running at about 60% of pre-COVID numbers. The issue is there's still a very high need for our service and a demand from participants, but they're looking for alternate ways to access these services. So our pilot program model looks to explore continuity of care by using this integrated care model to deliver services across the continuum of community-based services. We look to use a 3-pronged approach, leveraging medical adult daycare, home visits, and virtual visits to provide this comprehensive care to the state's most vulnerable population. Again, we know that this can also reduce more expensive care, such as nursing homes, hospitalizations, rehospitalizations, and emergency rooms. Because of the variety of services that can be offered through this integrated care model and the consistency of the care team, individuals will always know who to call when they have a need. The benefits of this model in using that integrator to help defragment care through the coordination of services will improve clinical and social determinant of health outcomes, reduce duplication of services, and also help drive down costs. I respectfully request the committee to issue a favorable report on House Bill 1051, and thank you for your time.
Thank you very much. Dana Kaufman.
Thank you very much, Chair Kelly. For the record, Dana Kaufman, and I'm here on this bill for Maryland Association of Adult Day Services and the Maryland National Capital Home Care Association. And we, both organizations support the bill. I don't have that much to add from Mr. Wright and Mr. Popham. And I think the main reason for our support is, again, the state needs to continue to look to build our community services and ways to enhance those community services. This is a pilot program, it's voluntary, but the information that can get gleaned will help to better plan and make changes to programs in the future. So with that, I would urge a favorable vote. Thank you.
Thank you very much. Do we have questions from the committee? Giving you all just a second, just in case, but it looks like we do not. Which concludes the hearing on House Bill 1051. Thank you, everyone. Moving right along, House Bill 972, Continuing Care at Home Certificate of Need Exemption, is also a Delegate Kelly bill. So I will present that and then pass it on to my panel as well. Just want to get started here. Thank you, Richard. So House Bill 972, I really dig this bill. If you're anything like me, I had 4 grandparents who got to live out their final decades at a CCRC, continuing care retirement community. And I was envious of that. And I've always wondered how I could afford such a thing, knowing that I don't think I can on my salary. So House Bill 972 removes a barrier in current law that inhibits CCRCs from launching a program designed to allow seniors to age in place at home. Recent AARP surveys indicate that 90% of Americans who wish to age in place at home for as long as possible. So we are all familiar on this committee with the CCRC model, the continuing care retirement community. Residents who move into a CCRC have access to a variety of services and care options to support them as they age and as their needs increase. In general, CCRCs charge an entry fee and then monthly fees. And then typically they offer independent living, assisted living, and skilled nursing options. And residents can access the level of care that they need as they need it. However, CCRCs can be financially out of reach for many seniors, and they also require residents to move onto campus. A new model for aging at home called Continuing Care at Home is growing in popularity across the country. As the name suggests, a continuing care at home allows individuals to pay a one-time entrance fee and then a monthly fee for a package of long-term care services designed to enable them to live at home as their care needs increase. Continuing care at home services can include care coordination, home health aides, medication management, and if needed, placement in assisted living or skilled nursing facilities. Continuing care at home is a more affordable option compared to moving into a traditional CCRC. A typical 75-year-old individual might expect to pay $26,000 to $66,000 to join Continuing Care at Home program, and monthly fees can generally range between $400 to $600. Sounds like a lot of money, but when you compare that to the entrance fees at CCRCs, they can run into the hundreds of thousands of dollars. CCRCs across Maryland are interested in establishing continuing care at home programs that would allow subscribers the same access to assisted living and nursing, skilled nursing, as the residents of a CCRC. However, our current certificate of need laws would not allow continuing care at home subscribers to access beds at the CCRC's assisted living or skilled nursing facilities. CCRCs could offer access to their other facilities such as social programming, fitness centers, or dining halls, or like my grandmother loved the water aerobics. I would love that. But they cannot give the continuing care at home subscribers that long-term care guarantee. House Bill 1051 eliminates this barrier and will help expand the availability of continuing care programs to more Marylanders. I am going to pass this off to the panel, starting with Allison Siborowski.
Madam Chair, I'm sorry.
Oh, I'm sorry. Am I starting with Aaron Greenfield? I'm starting with Aaron Greenfield.
Yeah.
My apologies.
Thank you, Madam Chair, Madam Vice Chair, Delegate Kelly. Thank you so much. My name is Aaron Greenfield on behalf of Leading Age Maryland, and we are here in support of House Bill 972. You have our written testimony, and I want to thank the Department of Aging and the Maryland Healthcare Commission, along with Delegate Kelly, for her sponsorship and for digging this bill. For some time, we have worked with the Department of Aging and the Maryland Healthcare Commission and their counsel to determine whether existing law permits a closed certificate of need at a CCRHC the ability to provide continuing care at home. After much research and review of the existing law, Mr. Ben Steffen wrote that the statutes are silent for the Maryland Healthcare Commission on this topic, and that this legislation would allow a closed CON to have a continuing care at home program. You have a copy of Mr. Steffen's letter in your file. As Delegate Kelly mentioned, continuing care at home is growing in popularity around the country, with 37 programs nationally, 5 in Pennsylvania, 4 in Virginia, providing coordinated long-term care to independent seniors who want to stay at home. With me, and at my request, are Allison Siborowski, the President and CEO of Leading Age Maryland, along with Megan Curtis from Edenwald, who will further speak to the importance of the bill. And with that, we ask for a favorable report, and we'll be happy to answer any questions.
Thank you so much. Let's hear from Allison Siborowski now.
Thank you, Delegate Kelly. Thank you, Madam Chair, Madam Vice Chair, and members of the committee. I'm glad to be with you today on behalf of Leading Age Maryland. I'm Allison Siborowski, and you have our written testimony, and Delegate Kelly and Aaron both did a fantastic job of laying out this bill. So I will be brief. But as we've heard today, not just on this bill, but more broadly, there's a need for us to invest and be creative in different ways of supporting older adults. And each of us wants the opportunity to choose how and where we age, where we receive healthcare. And this is one barrier, a small barrier, but a barrier that we've identified through our work over the years. And we are interested in working to educate the committee and answer questions that there might be. We represent most of the continuing care retirement communities in Maryland, and some of our members would like to be able to have, as part of a potential continuing care at home program, the opportunity to provide that skilled nursing care to their subscribers on their own campus. And so we appreciate the committee's time today, and look forward to answering any questions that might arise. Thank you, and I request a favorable report for this bill. Thank you.
Thank you so much. Let's hear from Megan Curtis.
Hi, good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. For the record, my name is Megan Curtis. I currently work at Edenwald Senior Living, and I'm here to support House Bill 972. As you may know, Edenwald is a nonprofit continuing care retirement community located in Towson. It was founded in 1881. It's been serving Baltimore City and Baltimore County for over 140 years. I have personally been employed at Edenwald for 25 years. We are home to over 400 residents across our independent, assisted living, and healthcare units, and employ approximately 280 employees. What we know in our industry is that typically 10 to 15% of age and income qualified people will choose to move to a senior living community, and that there are many older adults that have no desire to move to congregate living setting. These individuals then will try to age in place with limited supports and resources that leads them having to navigate the many challenges that can come with age. And when people have unmet needs, their health and manner in which they wish to desire to live their life can decline. We strongly feel continuing care at home needs to be able to grow as a viable option for people that want to remain in their homes, but have resources and support from an experienced organization to guide them through the many situations that can arise. Unlike Edenwald, many CCRCs do not have community beds, and because of regulations have been told they cannot serve non-residents. This is preventing many from entering a CC continuing care at home market. In addition, we would argue that continuing care at home residents are in fact contracted residents with the organization and should have access to such services if the need arises. For these reasons, I respectfully request a favorable report for House Bill 972. Thank you.
Next up is Ashley Bagwell.
Good afternoon, Madam Chair and members of the committee. I'm Ashley Bagwell here this afternoon on behalf of Health Facilities Association of Maryland. I'd like to thank you, Delegate Kelly, for introducing this bill. I don't want to repeat any of the important points made by the previous speakers, and so I'll just say that we're happy to lend our support to this bill, and we urge a favorable vote on House Bill 972. Thank you.
Thank you so much. Dana Kaufman.
Once again, thank you very much, Chair Kelly, members of the committee. Dana Kaufman for Lifespan Network. We also support this bill. And I think it's important to realize too that Lifespan Network is an association that represents not only CCRCs, but nursing homes, assisted living, and home-based services. And all of our members do support the ability for Maryland residents to be able to age in place. Because of this provision in law, we do not believe that the continuing care at home program has been as robust as it should be. So we do support making this change so that this program can actually be able to grow in Maryland. So with that, we urge a favorable vote. Thank you.
Thank you so much. That concludes the proponents. Do we have questions from the committee? Delegate Schlega.
Thank you, Madam Chair. And Megan, I see your name. I think you're still on from Edenwald. My grandmother, Kitty Lone, lived there for many years. I don't know if you remember Kitty. And
yes, I do.
Her brother, Carl.
Yes.
Yes, they lived to be 104 and 103 at Edenwald. And I spent decades there. I loved that facility. We were so blessed to have my grandmother and my uncle there. Great to see you guys. I'm a commissioner on the Maryland Commission on Aging, and we have a great program called Communities for Life. And I think what this bill is going to do is expand that. Is that right, Aaron? Because I know you've sat in on some of those commission meetings, and Communities for Life is great. And if I'm right, Aaron, I think that what this bill will take that program and make it better and bigger.
Yes, no, it does that, but for this continuing care at home, this particular bill addresses those closed CONs. But yes, as Allison said, it's part of a whole spectrum, and this bill fits within that. Yes.
Yeah, I think I'd encourage the sponsor, Delegate Kelly, to maybe call Rona Kramer. We put some money behind this. The pandemic has made it really hard to expand, programs within CCRCs for all the obvious reasons. And, it's a fantastic program. I'm excited to see that, there's an effort to expand it because it is really wonderful. Our only challenge in the program has been that kids like people my age sign our parents up for this program because we know how great it is. And then our parents unsign themselves up because they say, I don't need help. I've got you. So I think we need to, work on this on many levels. Thanks, Delegate Kelly. Anything I can do to help, let me know.
Thank you for that, Delegate Shalega. Delegate Lewis-Young.
Thank you, Madam Chair. This is a very interesting concept. As I first started to hear you explain it, I thought, well, why wouldn't I just hire an agency like Right at Home to come to my home and help with my care as I start to transition? And then as I continued to listen, I thought, well, maybe this is a hybrid program that links that kind of service with CRCs to transition you more smoothly. But my question is, could someone explain to me how this concept is a better option than hiring somebody to come take care of me in my home, an agency or otherwise, and then entering a CRC or another form of long-term care when or if I need that. I'm having a hard time differentiating with this integrated approach versus managing the steps myself.
So I don't know who wants to answer that, Aaron or Allison.
I'll turn it over to
I'm happy
Allison.
to- Yeah, I'm happy to address it, but I'd like to ask Megan if she can chime in as well, because she is a social worker and she works in this field.
Why don't we get the answer from Megan then, because we get one answer per question. Megan?
So the main difference between the ideas of just hiring a specific agency is that agency is going to just have a list of things that they're going to do for you, where continuing care at home offers you a plethora of different services, amenities, and care coordination that not necessarily every private duty agency can really give one person. Does that answer it?
In part, but I'll continue offline.
Okay.
Thanks.
Thank you so much. Delegate Hill.
Thank you. I feel better having heard Delegate Lewis Young's question, because I'm a little confused too. So at first I thought this was some way of doing a villages type model in a CCH or HRC setting, but those facilities like the one my mom's in, they have independent living and they have assisted living and they have a nursing home and they have that full range. So then it's talking about needing to exclude them from a certificate of need. So I'm a little bit confused. I understand this is just in, in a facility that's like a retirement community with this continuum, but I'm really having a hard time understanding, is this a village model and why can't they do this? I'm not understanding what they can't do now that this is allowing them to do. I'm sorry for my fogginess. I just don't get this.
Sure, I'm happy to address that, Delegate Hill. So as a baseline, continuing care at home already exists somewhat in Maryland. The regulations are under the Department of Aging. It's already allowable in the state. There's already a process in place. And an organization does not have to be a CCRC to start a continuing care at home program. So just kind of as a baseline. So for a CCRC like Edenwald, they don't have a closed CON, so they can admit folks for short-term rehab or long-term care into their nursing home. So if they were to start a continuing care at home program, they would be able to offer that to those subscribers, that they could come then to Edenwald for those services. There are CCRCs in the state that have beds in their skilled nursing that are only available to either independent living or AL living residents on the campus. And some of those organizations to expand and offer this program and explore offering this program to individuals in the broader community through continuing care at home. And so they currently would not be able to offer that level of care to their continuing care at home subscribers, if that makes sense.
Madam Chair, may I have a quick follow-up?
Sure.
So this is not talking about the assisted living folks already there. This is allowing them to offer their assisted living services to the folks out in the community, potentially get some of the NANA money that we put through before, because now they're offering it to people who need assisted living that aren't part of their community. So they become sort of a part of the village model. Is that what you're saying?
So it applies only to skilled nursing, assisted living, the CON product, the CON only applies to skilled nursing. So it would be, yes, it would be making available. And I love that you brought up the village model. That's such an incredible program. And I know we have many villages in Maryland. And it kind of is along that same philosophy of helping people to age in place. So it just applies to skilled nursing.
Thank you.
I'm looking for further questions. I don't see any more. Let me just double check. Okay, so I think that concludes the hearing then on House Bill 972. Thank you all. Next bill up was going to be 1073, but I think we're waiting for a couple of panelists. So we're going to put a pin in that and come right back to that While they get logged on, we will move to House Bill 971. Assuming Delegate Kipke is ready for that. Delegate Kipke.
Yes.
Is your panel great?
Let me just grab my folder here.
Perfect. So while Delegate Kipke grabs his folder, I will read you all the title. Delegate Kipke, Maryland House Bill 971, Maryland Medical Assistance Program, Substance Use Treatment Network Adequacy. We will hear from Delegate Kipke.
Thank you, Madam Chairman. I have a constituent who is testifying named Jason Hawkins. So he should be joining. I'm going to be very quick in my comments so that he can use some of my time. He came to me with a serious issue related to his son and substance abuse, his adolescent son. And it has exposed to me something that I would have never believed to be true, that Maryland has a real lack of access to residential substance abuse treatment for minors. And this bill, it's required to be covered through Medicaid, but the state doesn't have this in the network for Medicaid. You have to go out of state, essentially. So I'm going to stop there. I'm glad to answer any questions, but I will let Jason Hawkins tell his story. Thank you.
So much, Mr. Hawkins. It looks like Jason Hawkins is not here yet. But I'm sorry, Delegate Kipke, to put you through this. You did a great introduction. We do have all the panels here for 1073. So we will go back to that and then return to 971, and that will give Mr. Hawkins some time to arrive. My apologies.
Works perfectly. Thank you.
Excellent. So House Bill 1073, Delegate Cullison, Health, Accessibility of Electronic Advanced Care Planning Documents. Delegate Cullison.
Thank you very much, Madam Chair, and thank you for your indulgence and patience. Thank you to Chairman Pendergrass and Vice Chair Pena-Melnick and the members of the committee for the opportunity to present 1073 to you today. You have my written testimony, and I hope that you take the time to take a look at it. But today I want to respond to some of the issues raised in the letters in your packet. Over the years, we as a committee have made a commitment to individuals being able to make decisions about what kinds of care and treatment they would like when they're faced with end-of-life situations. We've created policies to inform our residents about the importance of affirming these wishes in two ways. One, identifying a healthcare agent who can express their wishes, and two, completing advanced care planning documents. All payers are now complying with the current requirement that they provide information to members and enrollees to the Attorney General's website, which provides examples of documents that can be downloaded and filled out. But two issues continue to exist. One, those documents are filled out and then stored in a place that's not accessible in case of emergency. Our former colleague, Dr. Dan Morheim, delegate, whose letter you'll see in the file, tells us about what it's like to be an ER doc and not know and not have access to information about what folks would want. And then just providing that link is not enough. There needs to be a strategic education, encouragement, and accessible opportunities to complete these plans so that Marylanders will be more prepared in case of an emergency. This bill contains the result of intensive work done by a work group during the interim, and I want to thank MHCC for leading that. But the language isn't perfect, and I'm prepared to recommend amendments that address the remaining concerns. First and foremost, MIA's concern. The language must be clarified that no payer, including insurance carriers and MCOs, would be required to help complete or store any of these documents, and they would not have access to them. Under this bill, these documents would be completed and stored on a secure state-approved technological platform that's totally behind a firewall from the payers. Second, to that end, language will be added that directs MHCC to determine how to develop that secure platform. We're fortunate to have CRISP, and they are likely to play a pretty significant role in this. There are concerns that smaller long-term care facilities may not have the technological or personal capacity to meet requirements. We can work with them about how to achieve the goals of this bill in their settings. Hospice facilities talk about not being connected to CRISP. We can address that, either by making those connections, or in the case of hospice, the individuals have already made self-determination. The AG's letter suggests that in order to have a healthcare agent, you have to have an advanced care document That was never raised in any of our discussions, so we can talk about how to rectify that. This bill is designed to help Marylanders' voices be heard and their wishes be honored at end of life. It's a sensitive subject, but it's critical in this age of advanced medical treatments. So with that, I ask for your consideration and a favorable report of HB 1073, and I turn my time, Madam Chair, over to my panelist, Jeff Zucker.
Excellent. Mr. Zucker.
Thank you, Committee Chair, Vice Chair, members, especially Delegate Cullison, for your leadership on this incredibly important issue. It's an honor to be with all of you today in support of HB 1073 and to join the many stakeholders from the payer, provider, community, and consumer-facing arenas that have worked for years on all the issues, the clinical, the legal, the technical, the public policy, the consumer engagement aspects of this issue. This issue is now very, very easy. Every reasonable objection or point of confusion, I believe, has been discussed, explained, clarified. So the bill before you today reflects an amazing amount of consensus and teamwork. And let me use an example to show you how simple this really is. This is the time of year when we're all preparing our taxes. The IRS mandates they be filed digitally unless you choose to opt out. What you have to do is, as the consumer, make the choice if you're going to do it yourself or hire a professional to help you do it for you. In the do-it-yourself model, there are lots of websites that have satisfied security and privacy concerns that actually get links to the IRS. So you just fill out your answers to questions, you push a button, and a form goes to the IRS. Sometimes you'd hire a professional and give them the ability to file that for you. This information is incredibly personal, very sensitive, and private. No different than the sensitivity, the personal nature, and the privacy associated with your answers in an advanced care plan. The Maryland Healthcare Commission has already done this amazing amount of work over years to make all that technical link stuff behind the scenes already in place. But what's missing that the tax world has is a consumer workflow, awareness, a deadline, a normalized stream of communication at various times throughout the year in your lives to remind you to update your plan, make sure your plan is accessible, or to create one if for some reason you don't already have one. The tax world has billions of dollars in radio and print ads and Super Bowl commercials and employers and financial institutions that send you tons of pieces of paper to remind you about taxes and all sorts of tax forms. But healthcare doesn't have any of that sense of urgency and that focus. But this legislation can trigger all of that. This is the last mile, the piece that empowers organizations to actually touch people before they become a patient. And especially before you are in a crisis. That's when the information is needed, but that's not the time to ask the question. It's as simple as a health insurance plan, sending an email every year, maybe during enrollment or re-enrollment or on your birthday, saying that they want to help you get your voice heard in your care and reminding you to update your plan. It's as simple as a medical record for a primary care doctor or a long-term healthcare facility being connected to CRISP, just like the emergency room medical records are. It's as simple as the driver's license being altered just a little bit where it currently asks for organ donation information from you and links to a database to just connect the advanced care plan piece to that as well. Over 1 million people in Maryland have already spent the time and money to create a document. But as Delegate Cullison just said, they're in a shoebox somewhere and it's not accessible when needed. Millions more citizens don't even know this is possible. And again, this last mile is that communication outreach. And as Delegate Cullison said, this piece of legislation is a classic example where you say the legislative process is the art of the compromise. This bill is not perfect, but it works and it's easy. And I've been in this space for 15 years, looking at digital advanced care planning and disruption around the world. And I'm confident this piece of legislation from Maryland is the next logical step in this decades-long effort you have all, and your governor and your leadership has set out to ensure that every Maryland citizen can feel confident they can have a voice in their care and doctors can know how to treat them. I'd be happy to answer any questions and really appreciate the chance to be with you today. Thank you.
Thank you so much, Mr. Zucker. And just to remind the members of the committee that he went over because he had Delegate Cullison's extra minute and 40 seconds. But thank you for being cognizant of the timer, even when it wasn't running. I appreciate it. You were spot on time. Next up, we have someone from the Maryland Healthcare Commission. I believe it is Ben Steffen, but it might be David Sharp.
Hi, good afternoon. It is David.
It is David. Welcome.
Good afternoon, everyone. For the record, my name is David Sharp. I am the Center Director for Health Information Technology and Innovative Care Delivery here at the Maryland Healthcare Commission. I'm here today in support of HB 1073, Health Accessibility of Electronic Advanced Care Planning Documents. Advanced directives are an important tool to help with advanced care planning as they include vital information for continuing or withdrawing healthcare. An advanced directive can also include the name of a healthcare agent that can make a decision for the declarant. The availability of electronic advanced directives across the healthcare continuum is best characterized as modest. Multiple strategies are required to increase the number of individuals that complete an electronic advanced directive and the naming of a healthcare agent. HB 1073 necessitates activities that must be completed by healthcare facilities, nursing homes, assisted living facilities, carriers, and managed care organizations, and select state agencies. These activities will lead to an increase in the number of provider-patient discussions, improved documentation, and the ability for providers to retrieve documented patient preferences, including a healthcare agent. The bill is the result of advanced directives work group that met over the interim. A common theme for many advocates was to advance directives is that all stakeholders have a role to play. House Bill 1073 requires the Maryland Healthcare Commission to coordinate the accessibility of electronic advanced care planning in the state. The stipulation builds on opportunities that have occurred in the past that will ensure that patients' wishes are not left unsaid. The MHCC thanks the many stakeholders that participated in the work group, and we are especially appreciative of the legislatures that are putting forward this legislation. With that, we encourage a favorable report out on the bill, and I'm happy to answer any questions.
Thank you so much. Next, we have Ted Meyerson.
Hello, Madam Chair and members of the Health and Government Affairs Committee. My name is Ted Meyerson, and I'm an AARP Maryland volunteer. People don't want to talk about advanced care planning. They think it's about dying, and few of us want to talk about that. But advanced care planning and advanced directives are not about dying. They're about maintaining the control of your health care by letting family, friends, and providers know what treatment you would want or not want, even if you could not speak for yourself. Advanced care planning and advanced directives are about how you want to live. Normalizing the conversations about advanced care planning would certainly increase the number of individuals who would take advantage of the benefits of having an advanced directive. Because House Bill 1073 would make talking about advanced directives commonplace, everybody's doing it. It makes it a very important bill, and it has AARP's support. AARP asked the committee to give it a favorable report. Thank you.
Thank you very much. Elizabeth Claiborne.
Hello, everyone. My name is Liz Claiborne. I'm an emergency physician. I practice at the University of Maryland Capital Region Medical Center, and I have a long-standing interest and passion surrounding death and dying and end-of-life care. And I can tell you that, both what, Ted just mentioned is very true. A lot of my patients do not like to broach the subjects of issues related to end-of-life care until there's a crisis at hand. And unfortunately, that is the worst time to have the discussion. But what's more than that, if they have taken the time to talk about it or discussed it with their family or healthcare providers in the past, I find it extremely difficult as an ER doctor to have appropriate access to that information when it matters most. So I'll give you an example. Just last week, I had a patient who collapsed outside of urgent care and went into cardiac arrest. She was resuscitated by EMS and brought to us, and we were able to get a heartbeat back and put a breathing tube in. And she actually woke up, was conscious, and kept pulling at the tube, asking me to take it out. And I thought she just was anxious, and I explained was not stable. It took us about 5 hours to kind of locate her records and figure out that she actually was a metastatic cancer patient and had an established DNR and did not want that tube in, and probably woke up and was wondering why that happened to her. And this is unfortunately not an uncommon story. And so it is extremely important that providers like me have the tools we need to protect patients' wishes and be able to access both what they have said, so they express their own voice, and the person who they've identified to speak for them. I can tell you this is something I encounter on a daily basis. So in addition to normalizing discussions around end-of-life care, I think this bill takes an essential step in giving me the tools I need to be the best doctor possible and protect my patients' wishes and sensitive, desires that they have expressed or have told their family relating to end-of-life care. I hope that you support this bill as well. Thank you.
Thank you so much. Do we have questions from the committee for the panel of proponents? Giving everyone a second. I see Delegate Riley.
Thank you, Madam Chair. I was just wondering, is the this particular form, this application that we're filling out, is it the same as what we used to call a living will, or is there a difference? And if there's a difference, which is better, do you recommend for patients to fill out? Or I don't know if you best answer that.
I don't know if it's called a living will. I've only known the document as advanced directive. So
I can help you with that if you'd like.
Oh, okay.
Dr. Claiborne.
I have to
Thank
teach
you.
my medical students and residents about this all the time. There is confusion sometimes between a living will and an advanced directive. Really, it has to do with the domain it lives in. A living will is more of a legal document that discusses, who is going to be the medical decision maker. An advanced directive is more intended for the use of healthcare providers. And so an advanced directive is really dictating to tell the healthcare team like me what the patient's wishes are in relation to specific interventions and who to contact. They do basically overlap and contain the same information, but one of them lives more on the legal side, whereas the advanced directive lives more on the medical side.
Okay, so
you should have both.
Okay, that's my question. So you should have both. Okay. All right. Thank you very much. Thank you, Madam Chair.
Absolutely. Chairman Pendergrass.
Thank you, Madam Chair. My questions, I think, are probably for David Sharp because they're kind of technical. There's no question that the intent of this bill is great. And we all want people to know what is needed at end of life. My questions are, there was a time when we were concerned that there might only be one vendor that would be participating in this kind of a process. And Mr. Sharp, could you talk about what has changed since our conversations some years ago, and how we know that there is a fair playing field for this? And second, why in the world is the MVA making a report about this? How does the MVA get involved in this? Or did I read something wrong?
Sure, and good afternoon, Madam Chair. It's a pleasure to answer your question. So the landscape has evolved. It's evolved over the years. And not only are there a number of what we would call independent advanced directive vendors in the market nationally, while we have one state recognized or entity here, others are free to apply. What we do have more than now than we did in years prior is that electronic health record vendor solutions are including within their technology an application that supports either uploading or recording of electronic advanced directives. The largest vendors, hospital vendors, and I'll name two, Epic and Cerner, have these capabilities, and they can be enabled at the provider site, and consumers can use their web portals that they connect to providers to add information related to advanced directives. I think we've heard other folks say this isn't the perfect, but it is a way and a utility that can record the information. As it relates to the MVA, your question here also equally is important. It specifically speaks to the education component that as an opportunity, I think we heard Mr. Zucker talk about education and informing and making people aware. And that's one of the responsibilities tasked in the bill. Happy to answer other questions, ma'am.
Thank you very much.
Delegate Hill.
Sorry. Oh, yeah, okay, mute's off. All right. So Delegate Cullison, just real quick, I heard you talk about some amendments, and I see Kaiser already, provides they take care of the patient, and they also have access to these documents. And I assume that the insurance part of Kaiser keeps it separated from the provider part of Kaiser. But I'm curious, when you talk about amendments to make sure there's a strong firewall, are you envisioning something that is even specific for that model and for Medicaid, since it's going to be held by the state and not just for commercial insurers?
We're hoping that the platform can be universally used between Medicaid and as I said, Chris may play a major role in what that platform is, which already exists. There's a huge amount of capacity there. So we have to see how this all works together. But I don't see us making two different platforms to adjust.
No, I mean, the firewall, you're aware that it may, that's fine. Okay, you said yes. That's fine. Thank you.
Thank you. I don't see any further questions from the committee for this panel, but we will turn to Matt Celentano, who has signed up favorable with amendments. Matt.
Good afternoon, members of the HGO Committee. My name is Matt Celentano. I am here today on behalf of the League of Life and Health Insurers and AmeriGroup. Forward with amendments on this bill. We are super happy to be here today. It is the result of a tremendous amount of work since Sine Die last year. There have been an incredible amount of work groups with the MHCC, and I want to thank Executive Director Stefan, Mr. Sharp, and Mr. Shields for leading the way. It was a lot of stakeholders, a lot of time spent together, and I think we got to a place of a lot of consensus, which is the way it's supposed to be, right? I also want to thank Glenn Schneider at the Horizon Foundation, who led some additional stakeholder meetings in between some of those MHCC work groups to see if we could try to continue to address other issues that kept popping up. We are happy to continue this discussion. We think this is incredibly important policy. The carriers will continue to be at the table, and we're supportive of making progress. So with that, I'll yield the rest of my time. Thank you for giving me the opportunity.
Thank you so much. Do we have questions for Mr. Celentano? Delegate Saab.
Thank you, Madam Chairman. It's nice to finally see Matt actually has testifying in favor on something. So what is, I know I was looking at the file, but I know you're favor with amendment. What is the amendment that you would be proposing? Because I didn't see the written testimony.
Delegate Saab, I think it would be the amendments offered by the sponsor. The bill that was introduced didn't, I don't think, reflect the recommendations of the work group report, which the committee should have in their possession. And it is my understanding that we will align further with that work group process in subcommittee, and we will be there to be supportive of it.
Wonderful. Thank you so much. Thank you, Madam Chairman.
Thank you.
Excellent. So that is the last question. So that concludes the hearing on House Bill 1073. Thank you. We'll move on to House Bill 971. We will return to that. I do see that Mr. Hawkins is here now. Delegate Kipke, if you want to kick us off again, we can hand it over to Mr. Hawkins right away. Just give us a quick reminder about the bill introduction for House Bill 971, Maryland Medical Assistance Program, Substance Abuse Treatment Network Adequacy.
Thank you, Madam Chairman. It's almost as if God has come down and said, I should get a second chance at this one. But anyway, so this bill, honestly, I think is a critically important bill that I was really surprised was needed. In the state of Maryland, I would have bet with great certainty that we had great access through Medicaid to substance abuse treatment for minors. As you know, we've done a ton of work to expand access, and adults have much better access today than they've had in the past. We've got a treatment desert in Maryland for adolescents. It's really quite sad. I look forward to working with you to solve this problem, and I would like to reserve the remainder of my time for my constituent, Jason Hawkins, for him to be able to tell the story which brought this to my attention. Thank you.
Thank you, Delegate Kipke. Mr. Hawkins.
I saw him. Yep, you're on mute, Jason.
I am so sorry about that. Good afternoon.
No worries. Go right ahead, sir.
First off, I want to thank everybody for an opportunity to speak on behalf of my son and his struggles with addiction. In 2015, my immediate family and I lost our 14-year-old daughter and Bradley's sister to a 6-month battle with cancer. This started a downward journey that has culminated in residential treatment in Pittsburgh at George Junior Republic, a financial free fall for his mother, culminating in him moving 6 times and 6 schools in 5 years, along with 4 significant deaths in our immediate family between my ex-wife and I, included in that. The last place that he was living in an environment with relatives that exposed him to multiple different drugs over my objections with him not living with me. We've had him in the ER 3 times, once sending him to Shepherd Pratt Stabilization Unit, once for an overdose and once for a suicide attempt. From 14, we've tried to get in-state patient resources to help, and the last center closed 3 years ago because it was defunded. We've tried outpatient services with co-treatment of his mental health challenges and substance abuse with a heavier focus in the last 2 years. Finally, last April, it was recommended by his probation officer that he was admitted to Spring Grove Hospital for evaluation, which is typically a 4 to 6 week stay. He was there for almost 5 months, and I'll come back to why. Spring Grove isn't a facility for a case like Bradley to be a long stay. While in the facility, the level of medical care was borderline gross negligence. After speaking with the medical staff for more than once to immediately notify me when there's a medical issue, he fainted. As an example, he fainted at 11 a.m. One morning, and I wasn't notified till 3 o'clock in the afternoon. In a second incident, he complained about abdomen issues in which he was given a CAT scan, and the med staff said there was nothing noticeable. Come to find out that on a Tuesday, I was notified that the med staff, due to a pharmacy error, had been double dosing him for months, and they knew it on that previous Friday. In that same meeting, it was discovered that he also had a small lesion on his liver. Thankfully, it's not cancerous. It's not an issue. Side note, kids aren't being recommended to inpatient facilities in the state of Maryland because the substance abuse specialists in these facilities are not performing an ASAM assessment. If you don't know what that is, that's the American Society of Addiction Medicine, where clinicians standardize a scale, a number scale. And once Bradley was assessed, he was over a 3.1, which is suited for an inpatient. He was in Spring Grove for 5 months because the court ordered DJS and MDH to copay for the inpatient treatment, regardless of if Medicaid covers it. Both would not allow. Both basically said that they didn't have any money and that they weren't going to fund it. He was in there an extra 5 months because the Department of Mental Health refused to answer emails and calls until his lawyer requested to hold him in contempt. And when they showed up, a lawyer showed up and was significantly underinformed about the case, just somebody smug there to read papers and do their job. So in summation, I'd like to get Marylanders sooner so we don't have to see substance abuse issues throughout their lives by getting them services now so another family doesn't have to deal with what we had to deal with. And thank you very much to the committee for hearing me out.
Absolutely. Thank you so much for your testimony, Mr. Hawkins. Next, we'll hear from April Jarbo.
Hi, everyone. I'd like to thank everybody for giving me a chance to speak. My story is very similar to I think his name was Jason. My son also struggles with substance abuse. I work in treatment. I'm a substance abuse counselor. I help people every day, and I cannot help my son because there is no facility out there that they could be admitted to. We have 2 in the state of Maryland. They're private funded for adolescents. One's $1,200 a day. One is $1,900 a day. And we can't even begin to afford that. I'll let you know, it started when he was 12. He's now 16. 2 months ago, I took him to the health department to be assessed for inpatient treatment, hopefully to get some funding to get him in. Basically, they said, yes, we'll help. That was the day before Thanksgiving break, and he's still not in treatment. My son comes home every day. He's willing to go and ask me when he's going to treatment. And every day I have to tell him we're waiting on the health department to pay, to sign off on payment. He was sent to Johns Hopkins Hospital. He drank himself to a 0.226, was in a medically induced coma, intubated. Johns Hopkins basically told me, we don't know what to do. We have no place to put him, and sent him home. I called outpatient treatment centers. They told me he was too acute because he's been multiple psych ward stays, multiple airlifted to Children's National Hospital, sent to Johns Hopkins, just barrier after barrier after barrier. And I think this bill is so important because we know preventative measures work. We know if there's intervention when they're young, it might possibly keep them out of the criminal justice system, or possibly when they get involved with fentanyl or these opiates and this whole opiate epidemic. And, you know, my son might die. He might die, and nobody's listening to me and nobody's listening to him. So I'm here on behalf of all the parents that are going through the same struggle that me and Jason are going through. Please pass this bill. Thanks for letting me share.
Thank you so much for your testimony.
Good afternoon. Thank you, Madam Chair, members of the committee. I'm Ann Seacott, testifying on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence. We're very thankful to Delegate Kipke for bringing forth this very important issue. There's a dearth of services for kids in Maryland when it comes to substance use disorders, and frankly, other services as well. Treatment desert, I think, is a good term that you heard the sponsor use. There's no residential treatment for children, for adolescents funded by Medicaid in Maryland right now. Over the last several years, there has been a dramatic drop in the amount of outpatient services for adolescents. Programs have either closed or simply stopped treating young people and have shifted totally to adults. It's a serious problem. I think there's pretty uniform recognition about the increasing needs right now, especially because of the pandemic. We hear in debates on the floor, in bills in almost every committee, talking about some kind of need to address problems that kids are experiencing right now. And having substance use treatment is important. It's an important component. There's a big connection, as this committee knows well, between mental health and substance use disorders, where one kind of maybe causes the other or contributes to the other. So this needs to be part of the continuum of care. That continuum needs to be developed. It needs to be appropriately reimbursed, because sometimes the reimbursement rates for adults maybe don't apply to some of the additional needs kids have. The last thing I'll say is there's a bill being discussed right now in Ways and Means about screening of kids in schools, because that's part of what passed with Kerwin. And it's, well, should we really be doing screening if we don't have the resources to send kids to address their problems? And that is absolutely the wrong way to be looking at it. We need to make sure we have those resources. And if the data helps drive the funding decisions around this, then that needs to happen. So we urge a favorable report on the bill.
Thank you very much. McCall Gross.
Afternoon, members of the committee. My name is Michal Gross, and I'm an assistant public defender in Southern Maryland, where I represent youth. In 2015, there were multiple adolescent inpatient substance abuse programs in Maryland. While often they were used inappropriately to treat youth who were using marijuana or drinking alcohol, there was always the occasional youth with real substance abuse needs. So in the following years, as each of those facilities shut down or closed their adolescent units, there was a warning about this treatment desert that others have testified to. What happens when we have a youth who actually needs inpatient substance abuse treatment? Maryland agencies did nothing to prepare for that eventuality. While there are still options, there's a private facility in Maryland, they don't accept assistance. But they are willing to work with state agencies on a per diem basis, but those agencies are not willing to pay out of pocket. So youth are either sent home to outpatient substance abuse treatment providers or to lengthier programs that don't focus on substance abuse and sometimes don't even offer substance abuse services. And sometimes those youth are sent out of state. I know this because I've seen it happen. The results in treatment are disparate for youth who do not have private insurance. When a youth with private insurance needs inpatient substance abuse, their parents work with their insurance provider and find an appropriate program. What this bill would do is it would be one step closer towards ensuring that regardless of who provides their insurance, every youth has a chance for appropriate treatment. I just want to end by saying that we appreciate Delegate Kipke's leadership on this issue, and I want to thank Ms. Jarbo for sharing her story and Mr. Hawkins for the advocacy that he has done to ensure that this situation does not happen to another adolescent or their family. And we hope the committee will issue a favorable report.
Thank you very much. I believe that the last witness is not here. That's Haley Rizkala. Just want to make sure that Haley is not here before I go to questions from the committee. Do we have questions from the committee for this panel? Delegate Krebs.
Thank you. I guess I'll ask Ann this question based on the testimony of Mr. Hawkins and Ms. Jarbo. I'm looking at the Maryland Department of Health's letter of information. The question is, do we have a requirement for network adequacy for Maryland Medicaid patients, especially youth patients, as like we do with network adequacy for our insurance companies, which we've talked a lot about in this committee? And if we do, how does that affect this? And then the mental health parity question, this is substance abuse, mental health, the parity question about medical versus mental health and substance abuse. Is that part of Maryland Medicaid, just like it is with our insurers?
So the short answer is yes. The federal Mental Health and Addiction Equity Act, Parity Act, applies both to commercial insurance and to all state Medicaids. So there is to be network adequacy, as you all know, is absolutely part of those measurements related to network adequacy is one of the measurements related to determining if parity is being reached.
So how do we, as a state, we're not an insurer, but as a state, what's the requirement for us as the state of Maryland for Medicaid to have adequacy and parity? How do we enforce that or make sure we have it?
Well, the how do we make sure we have it is the funds have to be there to make it happen. I think that, the fact is we used to have a much more robust system of care for children in this state. And it was, I think there are probably a combination of issues that have led to the decline. There were issues around rates keeping pace. I know there were issues with some of the outpatient programs that had to close. There were serious workforce issues. They couldn't retain the staff with the special skills needed to deal with youth with these kinds of problems. So, I don't want to oversimplify that it is just about funding, but the part of what I think the testimony referenced before was how the elimination really of referrals from the Department of Juvenile Services as DJS stopped paying for treatment, that led to the closure of programs. So it's a very significant part. And I would posit that regardless of what's required under the federal parity law, I think there's a greater reason why we need to make sure we have this kind of adequate network in Maryland for kids.
I'm just trying to find, it seems like we already have a law in place that they must do it. The question is, how do we make sure it's being done? But I thank you for that answer. It's serious business. We'll look into it. Thank you.
Let's find a pro bono law firm and sue. I'm teasing.
Delegate Shalega.
Thank you. Mr. Hawkins, in April, I'm so sorry to hear about your children. Where is your son now, Mr. Hawkins?
He's currently in Pittsburgh, and unfortunately at George Junior Republic, they have a residential treatment center that unfortunately I'm not allowed to visit him as there was the second COVID outbreak. He may not get home till May, so there's a whole year of his life is gone.
And I know Shepherd Pratt has, from that county, and they have services for adolescents, but you're saying that even Shepherd Pratt doesn't have any, to Mr. Hawkins or Ms. Jarbo. I see Ms. Jarbo shaking her head no. So
no. I can give you the skinny on that. So they have stabilization unit. They just opened a unit for mental health issues for boys, but that program does not support comorbidity or co-diagnosis. Almost all of the programs in Maryland, including RICA, well, all the programs in Maryland I'm aware of, and I've done 2 years of
Hold on one second,
research into
Jason.
this.
Okay, there was some.
Go ahead. Keep all the
all right,
programs you
okay.
said, including RICA.
Including RICA. So including RICA, they all have little to none of the components needed for substance abuse, whether that be a residential treatment center or an actual rehab. None of them, and actually the surrounding states do not as well. So Virginia, Delaware, and I mean Pennsylvania has this residential treatment, but it's all the way in Pittsburgh, so it's not really anywhere close. And as far as I know, it's the only treatment center even in Pittsburgh for adolescents that that take Medicaid, because there's one place in the state of Maryland, which is Sandstone, that and they're fairly new, that does do adolescent residential treatment and residential and rehab for adolescents, but nobody at the higher state level of the Maryland Department of Health will have conversation with them, while the resource officers that work in individual counties, in Anne Arundel County and in Charles County, have both tried to start conversations to get this pushed up the hill, but it doesn't seem to be doing any good.
Thank you. Again, I'm sorry. I hope your sons are better.
Thank you. I appreciate that, and I'm here because, as the other parent said, it breaks my heart to have another family go through this. You know, the cause of death in the state of Maryland for adolescents, the second leading cause of death for 10 to 24-year-olds is suicide, and 50% of suicides involve drugs and alcohol. And I just want the committee please to consider that just in AA County, girl suicides have risen 30% this year, and or should I say within the last year, and boys are 3 times as likely to kill themselves. So we're going to lose kids before they have an opportunity to get treatment. I mean, if we have a broken bone, we go to the doctor and the doctor treats it, but we're not paying attention to the mental health aspect, that if something is broken in them, they need a cast to fix that. But thank you for your consideration, and thank you for your kind words.
Hawkins, we have a final question from Chairman Pendergrass.
Thank you, Madam Chair. The governor and the Secretary of Health have both trumpeted their concern for the issue of substance abuse and helping people in the state. We have a letter of information that is not very useful, as far as I can tell, from the department. And I'm wondering if it's possible that Heather Scheck or anyone from the Department of Health is here today to answer any questions or give us any report about what's being done to resolve this problem. Heather Scheck, are you here? Secretary Schrader, on this important issue that you're trumpeting your concern for, are you here? Thank you very much, Madam Chair.
That we're concluding the hearing on House Bill 971 from Delegate Kipke. It is time for our committee to take our 15-minute break. So we will reconvene for the second half of our agenda, the next 6 bills, in 15 minutes, which puts us at 3:32. So let's take a break now. We'll be back at 3:32 to finish the last 6 bills. Thanks, everyone. All right, hello, everybody. I think we're coming back. Let's make sure our cameras are all on. Thank you, everyone, for being so timely. I'm sorry for the odd 3:32 minute, but I just didn't want to round it up an extra 3 minutes because I know we all have a long night ahead of us at this point in session. So thanks, everybody, for reconvening in a timely manner. We're going to come back for the last 6 bills on our agenda. The good news is that there's only about 20 witnesses left, so should not take hopefully as long as the first 6 bills did. With that, we're going to hear from Delegate Kipke again. House Bill 974, health insurance, physical therapy, co-payments, co-insurance, and deductibles. Delegate Kipke, are you ready to present?
Yes, thank you, Madam Chairman. And thank you, colleagues, for the time to present this bill to you today. A few years back, I needed to use physical therapy after a interesting incident with a dog in my neighborhood to get my arm working properly. And I saw the value of that therapy. You know, I could have avoided it, and I think I would have had less use of my arm, and I probably would have more pain from that incident if I had avoided physical therapy. But I'm glad I went. It was hard work, but it really helped me with my quality of life. And so the physical therapist that I went to has expressed to me concerns about a problem that she sees facing patients where increasingly their copays are outrageous. $80, $90, much higher than what we're all accustomed to in the way of a copay. This has created a problem for a lot of people because they are now avoiding physical therapy or dropping out after a small amount of therapy, which is inadequate to help them with their needs. So this legislation is brought before you to bring a fairness to that market by tying the rate of copay to whatever in that same exact plan is for primary care. So it's a very simple bill, and now I'd like to turn it over to the panel. Thank you. Oh, one last thing. The fiscal note for the state plan has a I don't know if I'm going to check in with them, but if you do the math and you divide out the cost of the state plan and you divide it by the number of instances that it was used last year, it would be like, I think it was, my math was like $158 per visit. So I'm totally confused at that math. It just doesn't make sense. Obviously, for some people, their copay there may be some additional cost, but certainly not $158 a pop. So with that, I'll conclude. Thank you.
Thank you, Delegate Kipke. First up, we have JD Shepherd.
Hi, Dr. JD Shepherd, President, APTA Maryland. Madam Chair, thank you for the opportunity to speak in support of House Bill 974. This bipartisan bill is needed because patients see rehabilitation specialists at a much higher frequency than they do physician specialists. Therefore, we welcome the Chiropractic Association's amendment and thank them for their support. The typical patient sees their physical therapist once or twice a week over the span of 1 to 3 months. With some copays as high as $50 to $75, insured patients are unable to afford the care they require. In my clinic, we get reimbursed around $86 a visit. So these copays often account for over half the cost of treatment. This leads us to further question that fiscal note, where the increase comes out to around $275 a claim. The fiscal note likely does not account for the cost savings physical therapy can provide. In fact, a study showed that over $2,700 in savings when patients with low back pain receive early physical therapy with decreased need for surgery, opioid use, and imaging. Other patients benefiting would be the 30-year-old woman who continues to have concussion symptoms months after a car accident. She has to choose between her student loans and receiving care to return to work. The postpartum mother suffering from pelvic pain must choose between formula for a child and caring for that child without pain. The father of 3 who suffers a massive stroke, his wife must decide between her children's college education and her husband's ability to walk and talk. Physical therapists are highly trained movement specialists, but we are not reimbursed at the same rate as our physician colleagues. As a result, our patients are paying for a much higher percentage of their care with their copays. This legislation will rebalance the healthcare equation so that patients do not have to make these difficult choices. Thank you, and I ask for a favorable report.
Thank you very much. Do we have Mike Ukoa?
Hi. 1 second. All right. So hi, my name is Dr. Mike Ukoa. I am the Diversity, Equity, and Inclusion Chair for the Maryland chapter of the American Physical Therapy Association. I'm Vice Chair and the committee members for the opportunity to speak in favor of House Bill 974. I reside in Rockville, Maryland, and have provided care in various areas of Montgomery County. I provide outpatient services in homes and also assisted living facilities, primarily with older adults facing various orthopedic and progressive neurological disorders. In my time as a physical therapist, I have always sought out opportunities to provide high quality care to individuals from underserved communities. Older adults in many cases have reduced resources and familial support for medical needs. The prevalence of falls and treatment of subsequent medical conditions contribute significantly to the healthcare system. The financial toll for older adults falls is expected to increase as the population ages and may reach over 100 aging. In my experience, there have been many clients unable to see physical therapy specialists, clinical specialists due to unaccepted Medicaid insurance or significant out-of-pocket costs for treatment. One clear example of this was after evaluating a client, they presented with symptoms associated with benign paroxysmal positional vertigo or BPPV that require further assessment and treatment that can only be provided in a clinical space. And due to the out-of-pocket costs, they were unable to receive treatment and be further assessed by a vestibular specialist. Despite my treatment improving their overall functional mobility, tolerance for activities of daily living, and endurance, that particular client remained a moderate fall risk, primarily due to the limits of insurance. So that experience was a reminder for me that within the scope of physical therapy, There are definitely ample opportunities to positively impact our communities and optimize human function. So let's work to improve the care, access to care with the support of all communities who need it. Looking to have a favorable report for this bill. Thanks for your time.
Thank you so much. Next up, we have Roy Film.
Good afternoon, Chairman Pendergrass and members of the committee. I'm Dr. Roy Film, and I'm the Vice President of the American Physical Therapy Association of Maryland, and I'm a resident of Catonsville. I'm an assistant professor at the University of Maryland School of Medicine, and I served as the National Task Force Leader for Pain Management for U.S. Army MedCom's National Opioid Crisis Community Summit. And I'm here today to explain how high copays are one of the unintended drivers of the opioid crisis. 68% of Americans who use illicit opioids today started with prescription oxycodone, not street drugs. These deaths are not the physician's fault. Many physicians would prefer their patients to see a physical therapist, and insurers set copayments for specialist services, including PT, to dissuade utilization of those services. Meanwhile, copayments for pharmaceuticals are typically set much lower, often around $10 a month. Physicians have three basic options to help people who are in pain. They can perform surgery, they can provide drugs, or they can refer to a physical therapist. In most cases, surgery is not appropriate. And with PT often not being a realistic option due to high copayments, patients are often left with drugs as the only realistic option, and physicians feel ethically bound to provide some relief for these patients. This is one of the primary reasons why 91% of Americans who survive a prescription opioid overdose are prescribed more narcotics, often by the same physician. High copayments drive poor people to opioids. This would be a great idea if opioids were universally safe and effective, but they're not. Evidence has repeatedly shown within the past 10 years that early PT decreases opioid exposure and is significantly more cost-effective as well. The first line recommendation from the CDC is that non-drug therapy should be used for acute and chronic pain management instead. We should not be making it harder for patients and their physicians to follow recommendations that are based on the best evidence we have available. I urge you to give a favorable report on HB 974 and would gladly offer additional testimony or assistance in addressing these issues at a later date.
Thank you very much. Nancy Erickson.
Thank you. Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Nancy Marks Erickson. I'm speaking to you in support of House Bill 974 as a patient who has inclusion body myositis, IBM. IBM is a rare degenerative muscle disease with no cure other than exercise to slow progression. I know firsthand the devastating consequences disruption of my physical therapy treatment has on my ability to function. Without regular regime physical therapy, my ability to move around unassisted is impacted. PT is important in helping maintain the deterioration caused by my disease. Disruption to PT not only curtails my ability to work, but creates a loss of independence and makes it difficult for me to manage simple tasks on a typical day. House Bill 974 will work to eliminate a significant barrier to continuity of care by limiting the cost of copays for PT services to no greater than that of a primary care service. This is just one way insurance companies impose barriers to care. The ability to receive PT services is what makes the difference between maintaining not just basic function, but maintaining a quality of life. I ask you for a favorable report on House Bill 974.
Thank you so much. We do have one panelist signed up favorable with amendments, but first I will go to the committee for questions to the favorable panel. Any questions from the committee? I see no questions. Let us go to Louis Crivelli, favorable with amendment.
Hello, everyone. Thank you for having me today. Thank you to Madam Chair, and thank you to Delegate Kipke for raising this important issue. I am the Vice President and Legislative Chair for the Maryland Chiropractic Association, and I am also the chair of an organization called the Council on Chiropractic Guidelines and Practice Parameters. We are the profession's research organization. And there's a lot of significant overlap between the way chiropractors and physical therapists practice. So we do support, this bill as with our amendments that we also be included. I've been practicing for 21 years now in Maryland, in Prince George's County, and I just cannot tell you the number of times that I've had to overhear patients say, when we tell them what their copay is, whether it's $50 or $60, the first question that comes out of their mouth is that every time I have to come in? And we have to say, yeah, unfortunately, that's kind of how it works. The average person only sees their primary care physician maybe once, twice, 3 times in a year. But when they have to do a course of either therapy, chiropractic care, more often than not these days, they're together. Even the most conservative recommendations can still involve anywhere between 5 to 8 to 10 visits. And when the copays are $50, $60, $70, it's a significant amount of money, especially in poorer communities. Faced with these kind of decisions, I agree that patients will then choose to go the medical route where they can fall into the trap of opioid addiction. So we definitely support this. We're with you. And, we see this firsthand. And Delegate Kipke, you said it yourself, you see the value. Everyone else sees the value in this as well. So it's time to really take these barriers down and implement this important legislation.
Thank you very much. Questions for this panelist? I don't see any hands up right now, so thank you so much for your testimony. We will now move to the unfavorable, which is Matt Celentano.
Good afternoon, members of the committee. Madam Chair, thank you for the opportunity. My name is Matt Celentano. I'm here today on behalf of the League of Life and Health Insurers of Maryland, here today in respectful opposition to House Bill 974. We're opposed because, first and foremost, physical therapists are specialists. Treating a specialist like a primary care physician is inappropriate and undermines the reimbursement and cost-sharing structure and design to encourage primary care visits for preventive usage and healthcare outcomes. Because we know primary care and catching things early is better for outcomes and ultimately saving the healthcare system money, carriers have designed coverage along with the Affordable Care Act mandates, including metal levels, with cost-sharing considerations to encourage forward thinking. Well visits are $0. Sick visits are generally very low. Primary care is designed to be baked into your premium to encourage healthy behavior. Having physical therapists be lumped into this approach is inappropriate. The cost sharing is generally the same as any other specialist and should be treated like everyone else. Physical therapy is also not like a primary care physician well visit that's once a year. They're generally reoccurring, like we've heard, and therefore require a different level of reimbursement, same as an oncologist. Once again, linking physical therapy to a primary care appointment is inappropriate. We can't start to cherry pick specialists that want to reduce cost sharing for beneficiaries. It has the potential to bring the entire pricing framework that keeps premiums focused to come to a murky and unpredictable place. Lastly, I would ask that you refer to the fiscal note. It estimates an increase of $47.5 million annually to the state employee health program if the bill were to pass. I'm not sure how it will translate directly to the commercial market, but it will certainly believe that claims will increase and the impact will have impact on rates. While we don't know the exact impact, it's certainly concerning. And at the very least, we suggest sending this approach to the Maryland Healthcare Commission to analyze the impacts during the interim. We respectfully request an unfavorable report on 974. Thank you very much.
Thank you very much. Do we have questions for Mr. Celentano? I don't see any hands. Delegate Krebs. Here you are, Delegate Krebs.
I wouldn't want to let you down here. Matt, a question for you. After listening to Mr. Film and Mr. Crivelli and Mr. Akowa, talking about the non-drug therapy should be used first. And clearly, I think there's a lot of new data coming out about non-drug therapies to be used, or non-operative therapies, so operating on somebody's back or whatever. So does the health insurance industry look at the cost avoidance, or is there any way, I'm not sure if that's what you're suggesting, but the fiscal note all looks at what the cost is going to be for this, but what about cost avoidance for surgeries, or the opioid issue is a huge issue, obviously with pain. so is any of that ever looked at comprehensively along with, hey, avoiding, non-drug therapies being used? Is that work being done?
Delegate Krebs, I don't know exactly about that particular angle, but I do know that all the carriers have actuarial teams that are certainly looking at the cost impact now and cost impact later. And what you invest now to be paid off later, or the return on investment, if we're looking about taking the patient out of it and just looking at the balance sheet portion of it, I do know that is certainly a consideration on how carriers build their premium structure.
I understand, but it'd be interesting to see on some of these specific things like, back operations or things that are included in pain, what the cost avoidance would be. If
it is a very fair point, and I think that's exactly what the Maryland Healthcare Commission has done for you all on policy considerations in the past.
Okay, thank you.
Delegate Riley.
Thank you, Madam Chair. So, first of all, I support this bill wholeheartedly, but I hear what you're saying. So, and the issue is that you're saying that it's categorized as a specialist.
Yeah.
So we don't want to change that. But what about the other half of physical therapy? A lot of physical therapy, as we talked about, they're going to specialists to avoid going to surgery and so forth, which is very useful and stops them from using the opioids and everything. But what about, is there any way that we can maybe amend the bill to at least take in consideration those people that are going to physical therapy after a surgery? Because that's also very important, because my husband had back surgery, and one major thing as a follow-up to that surgery was he had to go to physical therapy if you want to get better. So is there any way that we can at least change it and cover those folks and have a better copay?
Well, Delegate Riley, I'm always open to having a conversation, and I can take it back to the members for sure. But I think that what you're sort of discussing is going from one specialist to another specialist. And if we start cherry picking the combination of services in general and deciding who gets paid more and who gets less, you sort of throw the whole system into whack. And that's why we have specific ways that we treat primary care physicians, and it's baked into the way the premium's built. And because of the HCA cost structure and the middle levels, that it's going to be very low cost to try to catch things early, to not have to pay for things in the future. The specialist angle is a little bit different. If you go to a surgery, it might be in conjunction with a physical therapist. When I can't make those medical decisions, and I don't think carriers should be either, but if you lump the specialists in the same sort of buckets, it's an even level playing field for those types of providers.
Gotcha. I mean, because once you have the surgery, again, the medical insurance is quite expensive there. And then if the physical therapy is required for the patient to continue to recover, I would think maybe we could figure out somehow to.
I mean, we're also operating in theoreticals too. And if you're having a surgery, a pretty impactful surgery, the vast majority of people are going to hit their deductible, and then there's going to be no cost share after that. So that's sort of the nature of insurance and why you have insurance. So you don't have to pay those huge costs after something sort of catastrophic happens to you.
Okay, so in that case, you're already saying that there would not be a large copay?
Once you hit your deductible, no.
Okay, for going 3 weeks or 3 times a week and so on.
If you have a significant, I'm not going to pick one out of the hat, but if you have a significant surgery that it requires you to have a lot of cost share in a hospital setting with specialist surgeons, most likely for the majority of people, you will hit your annual deductible. And then after that, you don't really have any cost sharing.
Okay, thank you very much.
Sure.
Thank you. Delegate Lewis-Young.
Thank you, Madam Chair. I think my question's going to be similar to the themes we've heard already, which is really a combination of what's in the best long-term interest of the patient and in the long term costs the least amount. And I'll give you a case study. I had a bad skiing accident years ago. Went to a chiropractor for a while, went to a surgeon who wanted to put me on prescription drugs, didn't take them for all the reasons discussed here. Eventually went to a physical therapist as recommended by my general practitioner. Gone. Haven't had a problem for years. So long-term interest of the patient, I was treated in the best manner possible for me, and I'm costing the health system less because I was efficiently treated. So my question is, instead of getting caught up on semantics of, well, this is a specialist versus primary care, why isn't the question what's in the best long-term interest of the patient as it intersects with the least cost to the overall medical system?
Delegate Lewis Young, you're preaching to the choir. I think that is an incredibly valid question. First of all, I'm glad you're better from your skiing accident. I had a similar experience where I had a sciatic nerve prop issue and went to lots of different specialists, was very reluctant to go to an acupuncturist. I eventually went to the acupuncturist because my wife made me. And after 2 treatments, my sciatic nerve was gone. All right. But I had to spend a lot of money to get to that point. That is sort of, unfortunately, the nature of our healthcare system. Now, I will say, if it wasn't based in fee-for-service type payments, we wouldn't be encountering the situation. If we had more of a value-based model where we actually were focusing on healthcare outcomes instead of the number of visits, that would make a tremendous difference. And that's something we could do now if we had the will to do it.
Thank you.
Smooth, Mr. Celentano. Okay, I think that is the last question. So that concludes the hearing on House Bill 974. Thank you to all of the panelists. Next up, we have Delegate Carr, House Bill 820, Health Insurance, Pediatric Autoimmune Neuropsychiatric Disorders, Modification of Coverage Requirements. Delegate Carr.
Thank you, Madam Chair. Good afternoon, distinguished HGO colleagues. For the record, I'm Delegate Al Carr, here to present House Bill 820. It expands the covered treatment options for an autoimmune disease that affects children, known as PANDAS or PANS. We have had a number of bills on this topic over the years. Most recently was a bill in 2020 that did pass, giving coverage. So this bill is a corrective bill. It's intended to remove language that restricted coverage for one brand name medication, Rituxan, for the treatment of PANDAS or PANS. I ask for your favorable report. I will turn over the remainder of my time to my panelist, Caitlin.
When you're ready, Madam Chair. All right, great. Good afternoon, Chair Kelly, Chair Pendergast, and members of the committee. For the record, Caitlin McDonough with Harris, Jones, and Malone, also representing Genentech, here in support of House Bill 820, and I'll thank Delegate Carr for working with us on this issue. As Delegate Carr discussed, this legislation is a corrective bill that will clarify Maryland's current statute relating to PANDAS coverage to ensure that there's fair and equitable access to all available treatment options as prescribed by treating practitioners. Currently, there are no FDA-approved treatments for PANDAS, so it's important that the decision on treatment be determined between the treating practitioner and the patient and their family or caregiver, since we are talking about children. The original intent of the statute that passed in the 2020 legislative session was to permit coverage for all available treatment options as prescribed, and House Bill 820 provides a technical fix to address language included in that bill that alludes to one single specific product. We believe that could lead to confusion about what is actually eligible for coverage. Given how quickly treatment and options evolve and science advances, we believe it's a bad precedent to name specific medications in statute when coverage is intended to refer to all appropriate therapeutic interventions. We believe House Bill 820 addresses that issue. We thank Delegate Carr for introducing the corrective language and urge the committee's favorable consideration. Thank you.
Thank you. That is the entire panel. Questions from the committee on this bill? Giving everybody a second just in case. All right, my favorite bill hearing of the day. That concludes the bill hearing on House Bill 820. Thank you, Delegate Carr, for your very efficient hearing. Next up, we have House Bill 830, Delegate Lewis, State Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists, Physician Members Repeal. Delegate Lewis.
Thank you, Madam Chair. Esteemed colleagues,
Chair Pendergrass and Vice Chair Pena-Melnick, Robin Lewis, on behalf of House Bill 830, State Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists, physician members repeal. The title of this bill pretty much tells you what the bill does. It proposes to change membership of the State Board of Examiners for Audiologists et al. Now, you guys will, rather not to be so informal, my colleagues will recall that changing the membership of clinical oversight boards is not unusual. We've done it before. Many of you will remember that just a year ago, we changed the membership of this very committee by adding music therapists to its roster. The change proposed in the bill before you would reduce the size of this board. Under current statute, the board consists of 15 members. 2 of those members are licensed physicians holding a certification from the American Board of Otolaryngology, also referred to as ear, nose, and throat physicians or ENTs. This bill proposes to remove those 2 physician specialists from the board. And the bill asserts that doing this will align the Board of Audiologists with 23 other state clinical oversight boards that also do not have physician members. This legislation is supported by a number of stakeholder groups, most of whom are here to speak in support of the bill. But it's important to bring to your attention the fact that there is opposition to this bill. I was not aware of the lack of consensus when I introduced the bill. I have since become aware of it and have worked hard over many weeks to listen to all stakeholders, to convene meetings and facilitate conversations with the goal of reaching understanding and hopefully consensus. At the time I submitted this written testimony, a final stakeholder convening had not been held. We've since had that meeting just last night. I think there's still room for conversation, and I expect some of the perspectives will come up when the supporters and opponents deliver their testimony. With that, I thank you for your consideration and respectfully request a favorable report. Thank you, Madam Chair.
Thank you, Delegate Lewis. Let's hear from Dr. Alicia Spoor.
Thank you. If you don't mind, Delegate Chair, I'm going to let my colleague Leslie Papel start us off.
Okay, Leslie Papel.
Okay. Madam Chair, Madam Vice Chair, and committee members, my name is Dr. Leslie Papel, and I've been practicing audiology for 40 years, the last 30 in my private practice hearing services. On behalf of the Maryland Academy of Audiology, we are pleased to be working with Delegate Robin Lewis to update the Maryland Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists membership. Historically, the majority of ENTs, about 83% in the US, are male. Alternatively, 86% of audiologists and 96% of speech language pathologists are female. As a provider of audiology services since 1982, I have developed good relationships with physicians and have never hesitated to reach out for medical consultation when warranted, as my professional code of ethics expects me to do so. With 2 mandated ENTs on the Board of Examiners and the board representing mainly female practitioners, I, as well as some of my colleagues, question that the presence of the ENTs on the board is for oversight rather than for participation. Audiologists earn an 8-year clinical doctorate and are the entry point to hearing and balance healthcare. Speech language pathologists are required to possess a master's degree since 1970 and also supervise speech language pathology assistants routinely. Both professions licensed by the state of Maryland maintain their proficiency with ongoing continuing education. As with other non-physician health boards, we have a successful history of servicing our practitioners, and the mandate for ENTs on the board is not warranted. None of the other 14 non-physician medical boards within the Department of Health in Maryland has a mandated physician on their board. Thank you for your time and consideration, and I ask for a favorable report on House Bill 830.
Very much. I did not get a panel order for this panel, but it does seem as though you had an order in mind. Do we know who wants to go next?
Madam Chair, yes, thank you. If you will, the next witness will be Gloria Petit-Claire. I have Dr. Alicia Spohr after that, followed by Mary Casper, and finally Dr. Brianna Holton.
Perfect. So let's hear from Gloria Petit-Claire, please.
Good afternoon. My name is Gloria Petit-Claire, speaking in support of House Bill 830. I retired as a speech-language pathologist after a 50-year career in education and healthcare settings, and I continue supporting MASH's public policy efforts at both state and federal levels. I'm a former MASHA president, director of public policy, and was a member of the Board of Examiners. In addition to my testimony, I ask that you review the letter of support from Dr. Candace Robinson, the immediate former executive director of our board. Over the years, changes were made to the board to revise scope of practice issues and to reflect consumer needs. House Bill 830 would correct the situation of having physicians assigned to our board. As they've said, we are the only Maryland non-physician board to have physician members. Why is that? I have colleagues who served on the original board. When I told a friend of mine from those days about House Bill 83, her reply was, well, it's about time. When the board was formed almost 50 years ago, the thinking might have been, could SLPs and audiologists manage their own board without physician presence? We have demonstrated our ability to do that. In 2003, 19 years ago, an identically numbered bill addressed the same issues. The bill passed in both the House and the Senate, but was vetoed by Governor Ehrlich. In my tenure on the Board of Examiners in the late 1980s into the 1990s, I cannot recall a time when we needed physician expertise to complete the board's work. The time has come to finish the work of the original House Bill 830. Thank you, Delegate Lewis, for sponsoring this important bill, and to this committee for your time and attention. I ask that House Bill 830 receive a favorable report. Thank you.
We have Alicia Spohr.
Perfect. Thank you very much. Good afternoon. My name is Dr. Alicia Spohr, and I am an audiologist and private practice small business owner in Howard County. I'm also the legislative chair for the Maryland Academy of Audiology, who represents the more than 500 audiologists licensed in the state of Maryland. As my colleague Gloria mentioned, legislation with the same intent was passed, but vetoed in 2003. At that time, a compromise was made, and the physicians became non-voting members for any scope of practice issue related to audiology and/or speech-language pathology. Since 2003, the physicians have made no attempt to integrate back into the board as full voting members 19 years ago. In addition, and on a similar note, House Bill 155 was presented by the Board of Examiners and mandates whose attendance is required in order to meet a quorum. One of each professional is required: an audiologist, a hearing aid dispenser, a speech language pathologist, and a music therapist. You passed the legislation following the lead of the Board of Examiners, leaving the physicians off of a quorum. It would appear by this legislation that the physicians are not needed to conduct business. Finally, at the most recent board meeting, which took place 1 week ago today, I strongly suggest that you review the recording and the written copy of that meeting. During the meeting, the board voted to oppose this legislation and further commented on the intelligence of legislators and alluded to their relationships as being out of touch. The erroneous observations of the board about you must be corrected by passing this bill. Thank you again for your time, and I look forward to a favorable committee report.
Let's hear next from Mary Casper.
All right. My name is Mary Casper, and I'm a speech language pathologist and the current public policy director and president-elect for the Maryland Speech Language Hearing Association. MASHA represents the more than 4,200 licensed speech language pathologists in the state of Maryland. I'm here in support of House Bill 830, and I'm pleased to be working with Delegate Robin Lewis to update the membership of the Maryland Board of Examiners for audiologists, hearing aid dispensers, speech language pathologists, and music therapists. I'd like to elaborate more on the composition of the Board of Examiners. It's comprised of 3 audiologists, 3 hearing aid dispensers, 3 speech language pathologists, 2 ear, nose, and throat physicians, and 2 consumer members. Legislation passed in 2021 adds 2 music therapists this year. In contrast, the Board of Physicians is comprised of 22 members, 15 physicians, 1 physician assistant, and 6 consumers. None of our Board of Examiners professionals are afforded reciprocity on the Board of Physicians. Further, all of the other non-physician provider boards in Maryland, including dental, massage therapy, nursing, optometry, physical therapy, occupational therapy, chiropractors, counselors and therapists, and social work. Again, none with physician members. With consumer protection as the purpose of the Board of Examiners, I do not find value or necessity for the 2 ENT physicians serving. The non-physician provider boards without physician members have incurred no greater incidents where public safety through the licensing process could not be fully addressed in the absence of physician members. Maryland has often been viewed as a leader in the professions of audiology and speech language pathology. The Board of Examiners does not display this leadership and rather suggests that we as speech language pathologists, fully licensed healthcare professionals, must be supervised by the ENT physician's presence on our board. I implore you to update the board's membership and keep Maryland in the spotlight as a leader in our professions. Thank you for your consideration, and to Delegate Lewis for sponsoring this legislation. I ask for a favorable committee report on House Bill 830.
Very much. Dr. Brianna Holton.
My name's Dr. Brianna Holton, here on behalf of the Maryland Academy of Audiology in support of House Bill 830. I've been a licensed practicing audiologist for over 24 years and co-own one of the largest and oldest private practices in Maryland, with 11 office locations. Multiple offices of mine share space with physicians, whom I have the utmost respect for, and have worked collaboratively as team members for years. As equals, the board is not the place where physician oversight should occur either. The attendance of the physicians to the Board of Examiners meeting is horrendous for a professional board. At the time I served on the executive board for MAA, the Department of Health and Mental Hygiene submitted the physician attendance record between 1998 and 2002. Their data showed that the documented attendance was only 52%. And since then, it hasn't been much better than that. In fact, 3 emergency hearings were held during the 2021 Maryland legislative session, and the physicians only attended 50% of them and actually missed 1 critical emergency hearing completely. Not only do we have support from MASHA and MAA, 2 prominent ENT physicians support House Bill 830. Dr. Alan Oshinsky, Chief of Otolaryngology at Mercy Medical Center, talks about the composition of the board. He said, and I quote, "The professional boards are capable to accomplish the Board of Examiners' mission without any physician oversight. Simply put, House Bill 830 legislation will eliminate the outdated membership requirements of this Board of Examiners composition, end quote. Dr. Alan Shikani, who's chief of otolaryngology at Union Memorial, Good Samaritan, and Sinai Hospital, stated that audiologists and ENTs already take a team approach and work collaboratively to provide comprehensive care. He further states, and I quote, "Personally, I do not see any need for oversight from my profession," end quote. Thank you for your time and consideration. And again, to Delegate Lewis for sponsoring this legislation. We ask for a favorable committee report on House Bill 830.
Thank you so much. That is our entire panel of proponents. Do we have questions from the committee? Several questions. Let's hear from Delegate Cullison.
Thank you, Madam Chair. I'm not really sure who to ask, so I'll let one of the audiologists or speech pathologists answer. Do audiologists or speech pathologists practice under the supervision of physicians?
I'm happy to answer this. This is Dr. Spoor. The answer is no. They might work collaboratively within a practice, but as you heard from Dr. Holton and myself, we are both private practitioners and do not work with any form of otolaryngologist under their supervision.
Right, there's no supervisory role of physicians with respect to speech pathologists and audiologists. Thank you. Thank you, Madam Chair.
Do we have any more questions from the committee? I don't see any more hands up. Let's move on to the opposition, which is coming from Oluremi Dean with the board. Welcome.
Hi, thank you, Madam Chair and committee members. My name is Oluremi Dean. I'm the Executive Director for the Board of Audiology and Speech. The hearing and speech field is a multifaceted industry consisting of allied health and medical clinicians. The mission of the board is to enhance the quality of the hearing and speech health care provided to the citizens of Maryland by ensuring that qualified and competent audiologists, hearing aid dispensers, speech language pathologists, and music therapists are licensed and compliant. The qualifications of our clinicians range from audiologists who are doctorate level healthcare professionals who can diagnose to hearing aid dispensers who do not diagnose but regularly refer patients to physicians for medical evaluation and treatment. The current composition of the board represents the multidisciplinary nature of the hearing and speech field. Our physician members are a valuable resource that the board is able to utilize when advice or consultations are needed from a medical perspective. Their expertise and insight on daily practices, education, and legislation help to balance the complex nature of this industry and also maintains a close relationship at all levels. We understand that there may be misunderstanding of the role our physician members play on our board. We also understand that some may be under the impression that our physician members are providing oversight or supervision to our clinicians. That simply is not the case. Our physician members may not vote on proposals that expand or restrict the practice of our licensees. And in my experience, we have never held a vote in which the physician votes were different from the rest of the board. As a matter of fact, we generally reach a consensus. We would like our stakeholders to understand that we believe audiologists and speech language pathologists are autonomous professionals. In spite of this belief, we believe that it is important to work collaboratively in a multidisciplinary manner with our medical professionals as well. The board believes that our physician members who are both female are valuable assets and important factors to ensure the safety of our patients. For these reasons, the board unanimously voted to oppose House Bill 830 and respectfully urges an unfavorable report. Thank you.
Thank you for your testimony. We have a couple of questions. Let's hear from Delegate Lewis Young, followed by Delegate Krebs. Delegate Lewis Young. I think Delegate Lewis Young is having trouble unmuting.
I'm unmuted now.
Okay.
I've got a sticky unmute button. I want to address this question to Ms. Dean. And I'm going to refer to some testimony that I saw, one of the attachments. It was from Dr. Spoor, and it was from the Maryland Academy of Audiology, and it's a summary of the board's meeting notes. And it indicated that since 2016, the ENT's involvement was limited to making motions to either adjourn or adopt the minutes, but no substantive comments. In your testimony, you claim that ENTs provide educational information at the meetings. So my question is, can you provide this committee with any documentation for the past decade or two that the role of the ENTs actually offered any educational information and wasn't just limited to adjournment or adopting minutes?
Hi, yes, thank you for your question. So just to clarify, as far as our physician members and what they offer to the board, I know that the public may not hear from them in open session. However, our physician members are vital when it comes to our closed session or disciplinary cases. We often receive questions from our audiologists and SLPs regarding different procedures they should or should not refer to our ENTs, which we so often forward to our ENT members to answer those questions as well. So as far as the asset or the resource to the board, our physician members are pretty much simply there to offer our board members the education that they need when they are trying to decide how to proceed with certain disciplinary cases, how to proceed with offering recommendations on certain scope of practice questions that we receive as well.
Is there any written documentation of that?
As far as closed session meetings?
Of educational value?
Oh, sure, absolutely. I have emails. I've been with the board for 1.5 years now, first as a deputy director and now as of October, the executive director. And I personally have emails that I've received from consumers and licensees that I forwarded to my ENT members to get that guidance from them. So yes.
Thank you.
Delegate Krebs.
Thank you. Delegate Young and I think alike. To follow up on that question, it seems like your answer to Delegate Young's question is that you don't believe that the 13 other members of the board are competent to take care of the disciplinary measures of their own board, that they need these 2 physicians to provide that expertise, even though they don't participate in any other discussions in the board, and they're also not present very frequently. So is that what you were saying, that the rest of the board is not competent to oversee their own discipline?
Absolutely not. So again, referring to my testimony, I did say that audiologists and speech language pathologists, we do acknowledge and believe that they are autonomous professions. They are capable, yes, we do agree with that. However, when it comes to assisting and making sure that our licensees are compliant, having our physician members on our board gives the board members an additional resource that they have readily available to them. So without having our physician members on our board, that will require our board members to reach out to physicians as consultations, which will accrue additional fees. We already have our physician members readily available to our board members when needed. And also our physician members are involved and are offering input in all discussions that we have on the board. So in regards to expanding or restricting the scope of practice of audiologists and SLPs, we haven't had any discussions that will require those changes since I've been on the board in the past 1.5 years. So there hasn't been a situation where our board members, our physician board members, weren't able to participate in discussions or votes.
All right, I'd like to just follow up on that question. In your testimony, it says, having physician members provide the board with an important point of view from a medical perspective is an invaluable insight on daily practices, and it goes on. But then the testimony that was given to us that was referred to by Delegate Young clearly showed, if this is accurate, you can check it out, that at board meetings, either absent or they never ever commented on anything. So my question is, I'm just asking the question. I would like you to look at that document, and in the 4 or 5 years that it goes back, tell me if it's accurate or not, or is it inaccurate? And they did actually participate in open meeting board discussion of policies. That's if you can get back to us. And the second thing that concerned me that I'd like you to get back to us with, in Alicia Spore's testimony, she talked about this board meeting that was recorded about this legislation, and the members suggesting about the snake in the wood pile, and that we were out of touch and stupid on this committee. I would just like you to send us a link to that testimony or link to that meeting so that we can view it ourselves, because we work really hard here to know what we're doing. And if that's really true, that they think we're out of touch and stupid, I'd like to know who said that. So if you could provide the link and also respond to the document that was provided to us of the last 5 years of the actual interaction with these two members, and just comment on that, I think it would be helpful for us as we deliberate.
Sure. And for the record, I hadn't received the document you are referring to, but I can speak on my time with the board. I can say last year, 2021, our physician members had an attendance rate of 90%. Since I've been on the board, they've been present at all regularly scheduled open session meetings, with the exception of a few emergency sessions that were scheduled probably within 2 or 3 days before that meeting. So it is definitely acceptable or explain. It shouldn't be an issue for them to miss an emergency meeting that was scheduled within 72 hours. So
and that's fine. If you could just go back to the document, it talks about the participation and their actual involvement in participating at each of these meetings. And if you could look at that, it should be available, I guess, through our testimony link, or maybe someone could get that to you. But
Sure.
Thank you.
Sure, I can respond to that. And also, just to finish answering your question regarding the recording, I can send that to you as well. I definitely am surprised and can say that none of our board members mentioned anything negative about the legislators here or legislators in general. So that is absolutely false.
Thank you.
Yes, thank you.
Let's hear from Delegate Morgan and then Delegate Hill. Delegate Morgan.
Thank you, Madam Chair. Ms. Dean.
Yes.
Aren't ENTs represented on the Board of Physicians as well?
That I can't speak to. I'm
Okay.
not sure. Yes.
All right, because I think there's 2 spots on the ENT board for the Board of Physicians. And I was just wondering if there's any other medical professional that has 2 spots on state boards. Do you have any idea about that?
As far as 2 spots, no, I am aware that the Nursing Home Board of Administrators does have a geriatric physician on their board, but I haven't done enough research on this bill to specify on the composition of each board.
Okay, thank you. I appreciate the time. Thank you, Madam.
Delegate Hill.
Thank you, Madam Chair. So I have to say, I was listening to the proponents and really understood what they were saying and was on, and then I listened to you, and I really do want to get more information. I appreciate my colleagues for the questions that they asked. When you, the first thing I want to ask is, when you get that information that Delegate Krebs asked for, I hope that you can also send us by specialty, audiologists, hearing aid specialists, et cetera, what the absentee rates in that time are for the other specialists, not just for the physicians, so that we have a baseline to compare. But I would like you right now to explain by example, without giving names, a situation in a disciplinary consideration, a disciplinary adjudication or what have you, where the physician's presence and participation was important, because that's what I understood you to say, is they may not have such a critical role for the day-to-day operations, but it's important during the discipline for explaining something about scope of practice, or perhaps what a surgery did and what would be considered inappropriate, and somehow the audiologist wouldn't know that themselves. So can you explain by maybe 1 or 2 examples what you're
Sure. I'll try to give you 2 examples. One recent case that we had, disciplinary case, was regarding the SLP who was performing research at Hopkins that most of our SLP members felt that an SLP should not be completing these sort of methods or procedures without actually holding a SLP license. This particular SLP did not hold a SLP license. However, in our statute, there are some exceptions for SLPs regarding particular procedures and processes and research. Now, since our SLP members were not educated or experienced with working in that research field, however, our ENT members were. So they were able to educate our board members on what will qualify the SLP to perform certain research procedures without holding a SLP license. So having them on the board was critical in that instance in regarding that particular disciplinary case. I can give another example as far as a consumer, like I said earlier, the audiologist who emailed me asking for guidance from the board, particularly from our audiology and hearing aid dispenser board members, asking if a certain newborn testing procedure should be referred to a ENT or a hearing aid dispenser if they were allowed to perform a certain procedure. Our hearing aid dispensers at the time could not adequately answer that question since they had not had experience with that particular procedure. However, our ENT members were able to offer that guidance and say, yes, I would definitely recommend this particular audiologist to refer this case to an ENT physician.
All right, thank you. Thank you, Madam Chair.
Absolutely. I don't see any more questions from the committee. So let's go ahead and conclude the hearing on House Bill 830. Thank you to everyone for the discussion on this one. Next up, we have a familiar friend back in HGO. Welcome, Delegate Turner, House Bill 821, Career Pathways for Healthcare Workers Program. Delegate Turner, I will remind you the HGO rules. You have 5 minutes to present your bill. You can share your time if you would like with your panelists. Your panelist also, Joshua Harold, will have an additional 2 minutes, as well as Aaron Dorian, who signed up favorable with amendments. Delegate Turner.
Thank you, Madam Chair. Thank you so much. It is so nice for me to be back home. I call it home. 12 years I was there. But anyway, I'm here today on Career Pathway for Healthcare Workers program. And you know, over 2 years ago, we would have not imagined that we would be in the middle of a global pandemic lasting this long, where we have lost thousands of Marylanders for COVID-19. Despite this, we must also realize that many lives would have been lost if it wasn't for our family health care workers and the sacrifice that they risked for their lives and expose their families. Although they have demonstrated many heroic acts of bravery, service, thousands of healthcare workers and leaving hospital, nursing homes, and crucial healthcare setting at an alarming rate. According to the United States Department of Healthcare and Human Service, Maryland is one of the 4 states that would experience shortage over 10,000 nurses by 2025. The Bureau of Labor Statistics have also project that Maryland will need 10,000 more nurses and then 10 within the next 10 years. We cannot ignore that data. The staffing crisis in healthcare impact the lives and the welfare of our friends, family, and neighbors and family members. To combat this, we must focus on roots of the problem. Poor working conditions marked by shorting staffers available for wages and lack of career advancement opportunities have created barriers. Opportunity pursue programs and certification and allow for career advancing would improve the lives of of workers and address the healthcare staffing shortage. This is being faced by all across the industry. After hearing from frontline healthcare workers, and we drafted this bill to establish a career path program where we should provide matching funds to employers, including hospital, nursing facilities, and related institutions to pay for training for programs for healthcare workers. These training programs will be offered by the Historical Black College and the University of Community College. To administer this program, the Division of Workforce Development and Adult Learning would oversee the operation and conduct the application and by eligible employers to apply for the program. Each employers must include the costs associated with this program, the details outline of this program, and assure that the employees will not have to pay for this program. To ensure effectively longevity, the bill would have a $50,000 cap for the grant given to the employer. To each grant would be valid for 1 calendar year. After any healthcare workers anticipating complete a training program, each employee would receive the following grants to provide a 10% increased wage for each employee. Colleagues, given this great need to replenish to create the best healthcare workforce in the nation, I'm asking the governor to appropriate $1 million from his or her budget for this program to keep accountability for this program. I am asking that an annual report be submitted to the division to keep the legislature informed. Passing this legislation will benefit our healthcare system and our families. I am asking this committee to vote favorably on this bill to take action to address our healthcare workforce shortage. I am asking you, and plus I want to thank also one of the nice delegates, Cheryl Landis, for helping me on this bill today. I want to thank her, give a shout out for her. And again, I'm asking for your favor report for this bill, good for a career pathway for healthcare worker program. Thank you, and y'all have a good night.
Thank you so much, Delegate Turner. It's always great to see you back in HGO. Let's hear from Joshua Harold.
Thank you very much, Madam Chair, Madam Vice Chair, and committee members. My name is Joshua Harold. I am the Regional Director of the 1199 SEIU Training and Upgrading Fund here in Maryland and DC, and I'm testifying in favor of House Bill 821. Healthcare workers are in remarkably high demand throughout the country, with considerable shortages in Maryland. To overcome some of these shortages, specifically in occupations that require additional mid-level skills, many entry-level workers complete specific occupational skills training. The 1199 SEIU Training and Employment Fund is a collectively bargained joint labor management fund that provides educational and job training programs to eligible members. We play a unique role in the career advancement opportunities that the members can access. Through tuition assistance and occupational certificate training connections, we assist the members in gaining the skills they need to advance in their career, in turn giving them the ability to play a vital role in the care model, providing exceptional services to their patients. Too often, the training we offer is not able to meet 100% of the needs of the members and is not accessible to non-members sharing the work environment. This underscores the need for the Career Pathways for Healthcare Workers program. A partnership between the healthcare employers and this fund will enable the investment in the staff to get them the increased skills they need to provide this exceptional service. Connecting this training with HBCUs and community colleges is a great innovation. Much of the training provided by the 1199 SEIU Training and Employment Fund is still facilitated in cooperation with local community colleges. Community colleges have become valuable partners due to their knowledge of current occupational skills needs and flexibility to build programs to meet those needs. For these reasons, I support House Bill 821 and ask for a favorable report.
Very much. Do we have question for the panel of proponents? Any questions from the committee? If not, we can move on to the favorable with amendment support from the Erin Dorian. Erin Dorian?
Thank you, Madam Chair and members of the committee. I'm happy to be here today in support of House Bill 821. For the record, my name is Erin Dorian, representing the Maryland Hospital Association. I want to thank Delegate Turner for introducing this important piece of legislation. As you've heard over and over and over again, Maryland is experiencing a healthcare workforce crisis. This has been building since before the pandemic and was exacerbated by more than 2 years living with COVID-19 surges. For example, in the last 5 months of 2021, hospital nursing vacancies increased by 50%. We know we cannot just rely on increasing the pipeline of new healthcare professionals, though that's an important strategy. We need to focus on the existing hospital workforce and provide career advancement opportunities for workers at every level. House Bill 821 will provide funds to supplement the programs already made available in through Maryland's hospitals and allow hospitals to grow their training offerings. You can see in my written testimony that we are recommending 3 amendments we believe will strengthen the bill's impact. First, we believe the list of training programs reviewed by the department should be developed with participating employer input to identify training programs that will help employees move from one rung of the career ladder to another. Secondly, we recommend that the General Assembly not legislate salary increases. Lastly, we suggest that these grant funds not be commingled with training funds negotiated through labor negotiations. We look forward to working with SEIU and other stakeholders as this legislation moves through the process, and we urge a favorable report on this bill.
Do we have questions for Ms. Dorian? I see no questions. That is the last. Oh, I see a question. Delegate Lewis. Thank you. Delegate Lewis, go ahead.
Thank you so much, Madam Chair. And thank you to Delegate Turner for bringing this important workforce bill. Thanks to the panelists. My question is directed to whoever's best poised to answer, perhaps the SEIU rep. But just looking at the more detail on the bill summary, workforce is so important, and it's the duty of the state to invest in workers, especially in the healthcare domain. I'd like to understand, this bill creates a grant fund, and the funds are used for worker training. What I don't understand is why hospitals are included in the employer category. What about community colleges in the state of Maryland? We have so many that are excellent, and that, may or may not feel sufficiently funded. I'm just wondering, do hospitals train healthcare workers? And are they competing with the public sector, education sector? Whoever is best to answer that. Thank you.
Mr. Harrell, would you like me to answer that?
Yes.
Okay.
Yes, please.
So hospitals provide training opportunities to their employees. They do not necessarily, they partner often with community colleges to offer those opportunities or provide assistance to their employees to go for those opportunities at the community college level. Sometimes they do partner with the community colleges to create skills-based learning opportunities, clinical opportunities when necessary, but it's not the hospital that would be actually doing the training. It would be the community college or the HBCU would be providing the educational component. The hospitals would be providing the funding to fund that educational component. And if needed, the clinical opportunities.
Right, because any clinical professional needs real world hands-on patient experience. I understand that part. So I guess, well, maybe I'll save this for subcommittee, but it's something that occurred to me. Thank you very much. Thank you, Madam Chair.
Absolutely. Any more questions? All right, that concludes the hearing on House Bill 821. Thank you, everybody, for your contributions. We have, it looks like 2 more bills. We can do it, everybody. Delegate Bagnall is next. House Bill 911, Health Occupations, Psychologists, Doctoral Degrees. Delegate Bagnall.
Thank you very much, Madam Chair. Good afternoon, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. For the record, I'm Delegate Heather Bagnall, District 33, Anne Arundel County, here on behalf of House Bill 911, Health Occupations, Psychologists, Doctoral Degree. You have my written testimony, so I will quickly summarize. I'm going to keep my comments brief to give my panel time to further explain the need for this bill. This is an important workforce development bill for the behavioral health workforce. HB 911 creates an additional avenue for clinical psychologists, allowing for postdoctoral clinical respecialization training in appropriate programs to enable psychologists to meet the educational requirements for licensure. This is specifically for postdoctoral psychologists who hold doctorates in a non-clinical psychology field. This pathway from meeting education requirements for clinical licensure for doctoral psychologists is already standard in Maryland's surrounding states, as well as within the federal government, within the VA and the military. Around 40 states have open criteria allowing requirements to be met without a full respecialization. I have submitted a clarifying amendment to make clear that the certificate is practice-oriented and issued by the Department of Psychology through an accredited doctoral degree program. I did reach out to the board in advance of the hearing, but didn't hear back before they issued their letter of concern. And I would point out that this bill deals strictly with doctoral psychologists, and the postdoctoral respecialization certificate allowed under this bill requires significant effort, to which the panel will speak further to that point. And the only postdoctoral respecialization certificates that would meet the bill's criteria are those from practice-oriented American Psychological Association accredited programs. So it is already a very high standard required under the bill. With that, I would like to cede my remaining time to my panel, and I respectfully request a favorable report on House Bill 911.
Thank you, Delegate Bagnall. Next up, we have Mark Trellinger.
Hello, everyone. I would just like to give some more information on this bill. I did submit written testimony. I would also like to thank Delegate Bagnall and the committee for considering House Bill 911. So in this situation, the U.S. Bureau of Labor and Statistics states that there's a need of 13,400 clinical psychologists per year between the years of 2020 and 2030. According to the APA, their accredited programs, which are practice-oriented, meaning clinical counseling or school, will only be able to meet about 35% of that yearly need by 2023. However, over half of doctorates earned in psychology each year are not from practice-oriented programs, which means other areas of psychology and its applications, such as research, industrial organizational, cross-cultural, etc. And it's possible that these persons can take a postdoctoral respecialization certificate in order to obtain the practice-oriented pieces in their education that they would not have. So what has happened in Maryland is that Maryland currently identifies 2 ways to meet the educational requirements for psychologists. One is a doctoral degree that is accredited by the American Psychological Association or Canadian Psychological Association, and they only accredit practice-oriented programs. The other one is designation by the National Register, or if they deem it to be equivalent, and this includes non-practice-oriented programs. However, a big issue became available in 2018 that made this route not really available to anyone graduating after that point, because the National Register nationwide ended its designation program and stopped providing equivalency assessments. So now the only way to meet the educational requirements is to have graduated from one of those practice-oriented programs accredited by the APA or CPA. And there's no way for these other professionals to retrain themselves without getting 0 credit for anything they've already done. So what this bill does is provide a definition of a postdoctoral respecialization to allow these people to meet the educational requirements for licensure in Maryland. It was crafted by the Mental Health Association of Maryland in conjunction with the Maryland Psychological Association. I won't belabor it, but as Delegate Bagnall said, nationwide, it's quite commonly accepted as a way for people to respecialize. So what's involved in these, I think, is very important. So a respecialization program is after the person's already completed all of their coursework and their dissertation and received a doctorate. And then they take the next 3 to 5 years, but it's in non-prax oriented. So they take the next 3 to 5 years to complete the exact same clinical coursework, practicum experiences, and year-long internship required of a doctoral degree student in these APA and CPA programs. This is literally the exact same coursework, exact same classes taken at the exact same time. In fact, they're sitting in the exact classroom with the people who are APA accredited doctoral degree students. It's literally the exact same classes. Also, sometimes there's a concern that people may not be appropriately qualified because of different admission criteria, but it's important to keep in mind that these individuals have already completed a doctoral degree and already completed their dissertation. And actually 1 in 5 students in APA accredited doctoral degree programs never actually finished their dissertation. And that's the main reason for people not to be able to complete those degrees. So these individuals have already shown that they have that level of quality and can already do that level of doctoral work. So the American Psychological Association does not accredit these postdoctoral certificates, even though they're housed within programs that have accreditation. But it's not a statement against their quality. It's merely due to a technicality that they only accredit doctoral degree programs. So they don't accredit certificates, not as saying that they don't support them. In fact, the APA has encouraged and recommended respecialization since 1982. That's for 40 years. And they reiterated that in 2019, encouraging them, and actually calls them advantageous to psychology and society because of the dual specialties and diverse backgrounds of these individuals. I do know that there was some concern expressed by the board, and I would just like to say that the board has actually given licenses to people who came from non-practice oriented programs that were not National Register designated nor APA accredited numerous times in the past, dating back to 1995. As recently as 2018, I brought this issue to their awareness in writing in 2019. Also in 2020, when I was asking for permission to be allowed to complete a respecialization and obtain licensure, I was told that there's no legal way that they can allow me to do so because the health occupations article doesn't allow them. Yet again, they also gave licensure to someone in this same situation in 2021, and they have not, to my knowledge, taken any action to look at the licensing that they have done of those people and see if they are a concern of public safety. So I'm kind of confused why the board would feel that way at this point in time or so strongly oppose this bill. I hope that you will all vote favorably to support this bill. Thank you for your time.
Thank you very much. We will hear next from Pat Savage. Is Pat Savage on?
Yes, they're unmuted, but I don't hear anything. Pat, we can't hear you. One second, I'll message them.
While we give Pat an opportunity to get their technology working, let's hear from Dan Martin. It's getting late in the day, folks. Is Dan Martin here? I don't know that Dan is here.
Shoot, I'm here. I'm here.
There's Dan. Hi, Dan.
I was on mute too. I was on mute too. 2 years, right? Jeez. Well, thank you, Madam Chair, members of the committee. Dan Martin with the Mental Health Association of Maryland, here in support of House Bill 911. I want to thank Delegate Bagnall for introducing it. I want to thank Mr. Trulinger for bringing the issue to our attention. It really is a workforce issue, just like what we've been talking about today. In the mental health space, Maryland is contending with a mental health workforce crisis that's limiting care across the state. We are home to 48 federally designated mental health professional shortage areas, including 16 entire counties in the state. And so as demand for mental health care continues to increase, we have to ensure that our law doesn't preclude those individuals who are qualified, willing, and able to deliver care doing so. Mr. Schulinger, went over all of the kind of concerns. I've seen the Board of Examiners of Psychologists concerns around, standard of care, quality, and, respectfully, for the reasons that Mr. Schulinger stated, I don't think that they're terribly convincing. As you heard, it's not different or less coursework. It is literally the same coursework, the same practicum experiences, and the same amount of quality and supervised experience. And so, we're experiencing a behavioral health workforce crisis. We need all the help we can get. And we support House Bill 911 and urge your support as well. And I hope Dr. Savage has been able to jump back on. If he's not, I'll just say that the Maryland Psychological Association supports the bill with the sponsor amendment too. So hopefully I can turn it over to him now and let him say that for himself. So
Thank you very much, Dan. Dr. Savage.
Can you hear me now?
We can hear you. Good job.
Thank you. Good afternoon, committee chair, committee vice chair, and members of the HGO committee. Thank you for the opportunity to address you today. I am Dr. Pat Savage, a licensed psychologist in Maryland, and I'm also chair of the Maryland Psychological Association's Legislative Committee. Today, I am testifying in strong support of HB 911 on behalf of the Maryland Psych Association, which represents over 1,000 doctoral level psychologists living and working throughout our state. HB 99 at its heart is designated to increase access to care while maintaining the quality of mental health care in Maryland at a time of unprecedented demand for mental health services. Some have called this the second pandemic that will be with us long after we emerge from COVID. HB 99 is an amendment to Title 18, as you have heard, of the Health Occupation Code that creates a third path to licensure for doctoral degree psychologists. The path, as has been stated, is for individuals who possess a doctoral degree in psychology that did not specifically train to provide mental health services to the public. This bill allows those who have an original doctorate degree to return for additional training via accredited program or universities that offer accredited programs, and they would receive additional coursework, clinical training, and supervised experience designed to be the same as someone who obtained a doctoral degree directly from those accredited programs. This path eliminates the need for individuals possessing a doctoral degree in psychology to obtain a second doctoral degree, saving years of time and thousands of dollars to provide desperately needed mental health services to the public, hence lowering an unnecessary barrier to practice. These recertifications, as you have heard, are already accepted as proof of adequate training and education to practice psychology by many other states, the VA, and the federal government. I want to emphasize that this bill creates a pathway for those who already possess a doctoral degree in psychology but did not train as a mental health provider. Pathway maintains the same level of education and training for providers who are licensed in Maryland, places no additional burden on the board which oversees the practice of psychology in Maryland. Once again, I ask that you provide a favorable report on HB 99. It is one small step of many that are needed to increase access to care in Maryland. Thank you for this opportunity.
Thank you very much. That concludes our proponents panel. While I give members a chance to raise their hands if they have questions, I'll let you know there is an unfavorable letter from the board, but they are not here to testify. Any questions from members? Delegate Hill.
Thank you, Madam Chair. Thank you, Delegate Bagnall. Obviously, we certainly need to do what we can to make more professionals in this field across the spectrum of training available. I'm a little confused. The National Register used to do this and then they stopped. And I was just reading online their application, and part of what they required was 15,000 hours of clinical training or something like that, or maybe 1,500. Maybe my zeros are off. So I'm not clear if anyone can tell us why they stopped doing this and what would be the clinical hours under this program, and if they're equivalent, why does the person who finishes only get a certificate and not a second doctorate? So I'm just trying to understand how this compares to what the mechanism used to be, or the pathway used to be, And if it's equivalent, why are folks getting a certificate instead of another degree?
I think I can answer this one probably. So when you're looking at the number of supervised hours in the respecialization programs, they do obtain the same number of hours. In fact, it's from the same type of internship, postdoctoral internship programs that that are often APA accredited, that are actually the same ones that somebody who graduated with a doctoral degree in psychology from an APA accredited program would go to. So they're literally the same, and it does meet that requirement. The reason that they don't get a second doctoral degree is only because they don't do a second dissertation. Literally everything else is the same. They do all of the same coursework and everything, but they just don't do a second dissertation. That's the reason that they don't get a second doctoral degree, because they've already done one and it's deemed to be not necessary. They get transfer credit for that dissertation work. As far as why the National Register no longer designates and these programs or provides equivalency, I don't know the exact details of it in depth. I know it's been discussed, and I know some people who are aware of it. I think it had to do with a lack of demand from the programs. Where APA accredited programs exist and everything, a lot of the programs were non-practice oriented that were National Register designated. And over time, less and less of those programs were maintaining their designation. And I believe it was a significant amount of work for them to do that and do the equivalency assessments. And with options available like respecializations and stuff like that, there didn't appear to be a need. But that, again, I cannot be 100% accurate that that's what it is. I'm repeating it as I remember it being told to me.
Okay, may I have a follow-up, Madam Chair?
Sure.
Thank you. So as I read this, it's a previous doctorate, but there's no there's no limit to what it will be. You could have a previous doctoral in nutrition, in education, in non-medically related things, and you do these additional 1,500 hours through a program that also gives a doctorate in psychology. So it doesn't matter what that previous training was. It's just that you've proven that you can write a dissertation. Is that?
Mark, I can handle that one if you like.
Yeah, go ahead.
That's not accurate. You have to have a doctoral degree in psychology, but not have specialized as a mental health service provider. So for instance, an IO psychologist who went on and got a PhD in IO psychology that might work in industry might decide, I'd like to go out and provide mental health services to the public. They would be the people that might go back and get a respecialization and get the training and education necessary to provide the services. So it wouldn't be any doctorate. They would have already had to have a doctorate in psychology.
I would also like to add to that.
We have one answer per question. So I've already shown a lot of leeway, but we can discuss this further in subcommittee. Let's move on to Delegate Kerr's question.
Thank you, Madam Chair. A follow up to Delegate Hill's question. Have you considered a dissertation option that would allow someone to get a second doctorate? You know, sometimes people have another research interest that they'd like to pursue that would be dissertation worthy. And it seems like you could accommodate both the additional credentials as well as a second PhD.
So someone could do that if they're in one of these programs. They could choose to do a second doctorate and, you know, then complete the program and have a second doctorate. But the issue with that is that it lots of times isn't necessary, as they already have a dissertation that's completed and completed that component. And it also, again, as Dr. Savage, you know, reported, it adds oftentimes an extra 2 or 3 years to the degree that they would be doing, including the additional cost and student loans oftentimes, and the longer time that it would take them to be available to provide these services to people, just because of, you know, doing a second research. Now, if they choose to, that option is available to them, but, you know, this allows them to not have to do a second dissertation because they've done one already, and to obtain all the appropriate clinical coursework and training.
So the short answer is yes.
Yes.
Thank you.
Thank you. Any more questions from the committee for this bill? If not, it concludes the hearing on House Bill 911. Thank you to everyone. Final bill of the day, we've made it. House Bill 982, Delegate Henson, Health Occupations Faith-Based Counseling Exemption. Welcome back, Delegate Henson.
Thank you, Chair Kelly. Yes, colleagues, you have made it to the last bill of the day. Thank you for the opportunity to be heard for HB 982. Thanks to Chair Pendergrass, Vice Chair Pena-Melnick, and all the members of the Health and Government Operations Committee. Maryland law defines counseling as assisting an individual, family, or group through the client-counselor relationship. The principles that are there include defining goals, helping them make decisions, helping plan a course of action reflecting the needs, interests, and abilities of the individual, family, or group, and using information and community resources that help people make social, emotional, educational, vocational, development and decisions. When we then think of the relationship between a pastor and a parishioner or a member of the clergy and those who they are caring for, there are fewer relationships that are more personal than the relationship of trust that's developed between pastors and their parishioners. They are often there to help people make decisions, help people set goals, help people understand interpersonal problems, and they often reflect the needs, interests, and abilities of individuals, families, and groups. Similar to what we define as counseling, I make the case that our pastors are indeed offering and providing counseling to those who call on them for help. There is only one problem there. Our health occupations article states that an individual may not practice, attempt to practice, or offer to practice clinical marriage counseling and family therapy and clinical professional counseling in the state unless you are licensed by the board. This means that faith-based counselors cannot be compensated for their services. They cannot advertise broadly or offer their counseling abilities without fear of running afoul of the health occupations article. HB 982 provides a narrow exception to our licensing requirements for faith-based counseling services. It defines faith-based counseling services as non-medical treatment that are exclusively religious in nature. And it gives some examples there: moral guidance, spiritual counseling, prayer, meditation. By way of example, if you think about a church or synagogue or wherever people worship, they are self-selected. It's not the same process as checking with your insurance company and looking for an in-network provider. We choose our religious affiliations based on our beliefs, our culture, and our community. If a person who has made such a choice finds themselves, for instance, grieving a loss or entering into a marriage, which, by the way, our clergy already officiate, this bill would provide a pathway for that clergy member to help them set goals, make decisions, develop a course of action reflecting their needs, interests, and abilities. Thank you for the opportunity to testify on this bill. Following me will be several members of the clergy who are there to provide support to those in their care and the members of their community every day. Thank you for your attentiveness and your open-mindedness to hearing this bill, and hopefully together we can work to uplift the important work that's being done by our clergy. Thank you.
Thank you very much. Next, we'll hear from Barbara Palmer.
Good evening. Thank you so much for having me. I appreciate it. I definitely want to acknowledge Delegate Jocelyn Pena-Melnick, who represents the district that my husband and I reside in. My name is Barbara Palmer. I'm the CEO of Kingdom Care Incorporated, and I pastor alongside my husband, Apostle Antonio Palmer, at Kingdom Celebration Center in Odenton, Maryland. And I'm also a board member for Leading Ladies of Integrity, who is an organization who strongly supports this House Bill 982. Almost 75% of Americans say that their approach to life is influenced by their spiritual belief. So it makes sense that for so many, their emotional needs are strongly supported from their spiritual church. Faith-based organizations have always been on the front lines, touching people where they are. Faith-based organizations for centuries have met the basic needs for those in the community. For someone who I've worked with, imagine being an African-American woman who has a strong faith and belief in God and depends on her church to support her. Imagine her losing 5 family members during the COVID-19 pandemic, not knowing where else to turn, but to her pastors and to her church family, knowing that in her culture, Black and brown people go to their church for support instead of the community. Faith-based organizations want to cultivate relationships with clinicians in order to make sure that not only our basic needs are met, but our spiritual and emotional needs are met as well. Thank you very much for your time.
Thank you very much. Let us hear from Antonio Palmer.
Thank you, esteemed delegates. Again, I am Apostle Antonio Palmer. I want to thank you guys for the opportunity to testify today. I want to especially acknowledge, just like my wife did, Delegate Jocelyn Pena-Melnick, in whom district we reside. I hereby testify in support of House Bill 982. I am testifying on behalf of the United Black Clergy of Anne Arundel County, and whereby I'm the president. And we are a community development corporation comprised of over 50 clergy members and churches throughout Anne Arundel County and South Baltimore. Together, we lend a wealth of experience in helping disenfranchised families and underrepresented communities who have been victims of poverty and unwarranted disparities and inequities. These conditions, whether social, educational, financial, or environmental, have left many individuals in unhealthy mental, emotional, and spiritual resolve. As pastors whom have decades of experience advising families firsthand, we are usually frontline responders to assist our communities when crises occur. The myriad of crises ranges from family members being victims of gun violence, police misconduct, and racial profiling, death of loved ones, lack of school supplies for children, financial illiteracy, mismanagement, and insecurity, lack of necessities such as food, clothing, or housing, and the list goes on. We believe that House Bill 982 can give pastors the necessary validation for the professional work that we're already doing to assist our partner professional counselors and organizations in the continuum of care. We all work together to bring healing to our community. The pastor and the church is equally valuable in the unity of the counseling collective. Thank you for the opportunity to testify today. Thank you again.
Thank you very much. Next, we have Cheryl Clark.
Thank you so very much. I am presenting today as a parent in regards to our bill today. Most people reflect on 2020 and probably think of situations that happened regarding COVID, but for me, it was more personal because my only son, I was aware of the emotional and mental health strain that he was going through. He was supposed to graduate, and he did graduate from high school, but just like others, he missed out on the formal graduation. There was no prom and all the other things that were supposed to happen. I was aware that he was going through something, but I thought it was going to get better. He went to college in the fall. And when he came home from college, he had the opportunity to have his own dorm room and just other things. So being an only child, I thought it would be a great experience. But I noticed that that didn't seem to be the case. I was aware painfully that what I thought was bad was now worse. And the situation, I expressed it to his primary physician, and the doctor encouraged him to be evaluated. That evaluation resulted in him being diagnosed with depression and bipolar. And John is his name. He had expressed the desire to go into the military. That eliminated that opportunity because of that diagnosis. So for the consideration of counseling, he was able to go, whether male or female. He had counseling opportunities, which were Christian. So he received the love of God, but not the word of God. So for faith-based counseling, faith comes by hearing, and hearing by the word of God. He needed to know that he is more than a conqueror. He needed to know that greater is he that is in the world. And those things he did not hear at the end of his sessions. So on today, I ask that you please consider this bill for those that would like to have the option for certified faith-based therapists. Thank you so much for the opportunity today.
Thank you so much. Next, we have Abraham Shanklin.
Good evening, everyone. I'm happy to be here to offer this testimony today. And so to the chairperson and to the Madam Vice Chairperson, and I greet everyone on the Health and Government Operations Committee and this legislative body. And thank you for allowing me to share my oral testimony. For the record, my name is Apostle Abraham Shanklin Jr., representing the Center of Transformation headquartered in West Anne Arundel County. I have a PhD in clinical Christian counseling and provide pastor and paraprofessional counseling to the congregants of my local church and local community. I'm a board certified belief therapist and a member of the United Black Clergy of Anne Arundel County. I'm for Bill HB 982, Health Occupations, Faith-Based Counseling Exemption. And it's been widely reported during the pandemic that parents with children ages 5 through 12 have reported their children showed elevated symptoms of depression, anxiety, physiological stress, and experienced overall worsened mental and emotional health. It has been felt through social determinants such as social isolation, remote learning, and the fear of the virus. The statistics are real for me as a frontline worker intervening and interacting with a population that's been gravely impacted by this COVID. And it literally goes unnoticed because the dots are not connected. And we're not just talking about missed classroom interactions with their teacher or sports participation. Oftentimes parents have not reached out to a professional counselor or therapist, but go directly to their local pastor or faith leader first. Faith has played a major role pre-pandemic, and I believe in greater role post-pandemic. This bill will help to fill in the gaps as frontline workers being trained by biblical therapists connected to a network of professional counselors to help with the grief, the depression, and the sadness increased by COVID. And then it allows us to refer up the serious matters of abuse, PTSD, and other diagnosable issues. So here we're not competing with the professionals. We want to partner with the professionals because we believe that literally it's all hands on deck. Thank you for allowing me to share. I support this bill and thank Delegate Henson for sponsoring this bill, and I welcome questions.
Thank you very much. Our final witness is Sonia Edison.
Thank you, Delegate Henson and committee members for hearing my testimony. My name is Sonia Edison. I've been a church member for over 40 years of my adult life, and the church has helped me in many ways. But as a parent of 3 children, having one child who spent over 10 years in the prison system, and the wife of 30 years to a husband who spent 17 years of our marriage on drugs, the church served as my place of refuge to find peace and strength. It was not the place I went to relive and rehash my home life. Over the years, I have found that there are many people like myself who are what I call in the gap, supporting others while suffering in silence between talking to my pastor and clergy or seeking clinical professional help. As a leader in the church, I've now been trained and I'm receiving ongoing training as part of the faith-based network, which allows me to help those in the gap and others by offering religious and spiritual support, and has prepared me to refer those possibly in need to seek clinical or professional service. Also to access resources such as housing, shelter, food, etc., and to seek guidance for reporting on abuse and those that pose a potential danger to themselves and others. As part of the training faith-based network, when people share their stories with us, we are there to support and help them with love and compassion. We serve as the first line of defense for those we see on a regular basis at church and in our community that we know are looking for a safe place to share. We love people and encourage a favorable report of this bill to assist us in reinforcing a strong, healthy community through faith-based support. Thank you.
Thank you very much. Do we have questions from the committee for this panel? I'll give you a second to raise your hands and let you know that we do not have an opposition panel signed up, but we do have letters in opposition in the file from the Board of Counselors and Therapists and the HGAU in the Attorney General's office. Delegate Krebs.
Thank you, Madam Chair, and thank you for bringing this bill. When I saw it, I was shocked to think that we are not allowed to do something that's been going on for my entire life. And I want to thank all of you who provide this unbelievable service to our patients. But my question is there any indication that they're not allowed to do? I mean, obviously this goes on everywhere. It goes on in our community. It's an integral part of our community. So how has it been allowed to go on for so long? And is there anything that is stopping it? What we're already been doing for, like I said, my entire life.
Thank you for the
I guess that's
question.
the sponsor of the bill. If there, I mean, or did you just find this and want to, what's the reason that we need the bill, even though I agree with you?
Thank you for the question, Delegate Krebs. The Health and Government Occupation article makes a very clear distinction between professional and non-professional services. So as long as your services are offered non-professionally, any of us are free to provide that type of care and support for anyone. But the distinction there is that if you're seeking to be compensated for the service that you're providing and the hours that you've spent and built into being able to be a provider, that is not available under our current law.
So what if you're a pastor and you just provide it as part of your pastoral services and they're compensated for that? Is that included as well? Do you know?
So if the pastor is compensated just on a salary and they're receiving a salary for everything it is that they're doing, if that salary or that fee for that service isn't coming directly from the person that's receiving the service, then that is fine. But let's say you're a pastor and you're spending your free time counseling couples in your church or helping people deal with grief, and you want to have those one-on-one interactions and you're not being compensated through your traditional salary. If you wanted to have that type of agreement, you would not be permitted to do that at this time.
Oh, gosh, thank you. I'm shocked that that's the situation, but thank you for answering that.
Chairman Pendergrass.
Thank you, Madam Chair. Delegate Henson, could you clarify who it is that you're expecting to pay for the services that isn't paying for them now? Is this the person who is receiving the services, or is this, for instance, a health insurance company?
Thank you, Chair Pendergrass. That is an excellent question that I spent some time with the bill drafter trying to make sure it was clear in the bill. As the bill is currently drafted, a provider that is not already able to seek reimbursement would not be allowed to seek reimbursement based on this bill. But what they would be able to do is have an agreement where the person who was receiving the services could compensate them directly.
Thank you.
Thank you. I see no further questions. Oh, wait, I'm sorry. Vice Chair Peña-Melnick has her hand up.
Thank you, Chairman. And it's wonderful to see you, Bishop Palmer and First Lady Palmer. I have a question, Delegate Henson. Have you had the opportunity to look at the Office of the Attorney General Consumer Protection Division letter and the letter from the Board of Professional Counselors and Therapists?
I did, and I did take an opportunity to meet with the Board of Professional Counselors and Therapists. I did not have an opportunity to meet with the Health Education and Advocacy Unit at the AG's office. And looking at their testimony, it was based on personal experiences and people they had encountered, and then a presumption that the quality of the services that would be provided by our faith-based practitioners would not rise to the level of being able to help people with transformative care. It was understandable that when people are seeking, help from the AG's office, when people are seeking help and the services that they received did not work, that would be a logical next step. So it stands to reason that those are the people that they would come in contact with. But the numbers of people, like the ones mentioned by Delegate Krebs, who have received counseling services from their clergy, and it has made a transformational difference in their life, I don't think that those folks are making their way to the AG's office or to the board there.
Yeah, and if I may just give you a suggestion, if you can contact Patricia O'Connor at the AG's office, that will be great. And if you need her information, let me know and I'll give it to you.
Thank you. I appreciate it.
My pleasure.
Delegate Rosenberg.
Thank you, Madam Chair. In response to the questions just a little while ago, is it your testimony that under current law, a pastor cannot be compensated by an individual for providing counseling?
Not directly. Not directly, Delegate. So looking at the outset of the bill on page 1, it links into there the section of the Health and Government Occupations article that it would be modifying. And in the first through lines 1 through 4, it puts the prohibition there very clearly about what you can't do without being licensed by the board. And so because you have that prohibition in place and you can't perform that service, and the definition of counseling is very broad, it does leave a lot of people who are providing these services every day in a place where they could be in a catch-22.
Thank you.
Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate, for this legislation. My question is, and whoever can answer, what kind of licensing or certificate would they need? Would it be like a peer counselor?
That's an excellent question, Delegate Johnson. We have made great strides to understand the value of peer support and to make sure that the services that we can provide as a state are as diverse as the people in our state. What this would be, it would provide an exemption to the existing licensing law. So it doesn't create a new classification of license. It simply gives them the ability to operate and to perform that service without having had sought a license.
All right, thank you. Thank you, Mr. Chairman. Madam Chairman.
No problem. Any more questions from the committee? I see no more hands up. So with that, it concludes the hearing on House Bill 982. Thank you to everyone for your participation today. Just a reminder to the committee members, we have a voting session tomorrow, and otherwise we are adjourned. Have a great night, everybody.